Ma'am, since if you can chair the session 1 also with us. Meanwhile, since there is no one, please join, ma'am. So we have Dr. Sunita Sharma. पहला CV लगा दो मैम का. Next page. Dr. Sangeeta Raj. Dr. Sangeeta Raj ka CV. Ma'am, would you please join us on the dais and chair the first session for us? And as and when the chairpersons join us, we'll invite them on the dais. All right, ma'am, so let's invite the first speaker. Yeah, there she is. You're starting. Ma'am.
Good morning, all of you,
Sure.
and welcome. And today we are starting a very good session. And the first speaker will be Dr. Sangeeta Pankaj. She will speak on adolescent ovarian tumor, a diagnostic and management dilemma for gynecologists. And to chair the session, I call upon Dr. Mamta Sinha. Neena Agarwal is not here. Rashmi Prasad, Vinita Trivedi. Anyway, one chairperson has come. She's enough to... Okay. So I leave this session to the chairperson.
Good evening, friends. Myself, Dr. Mamta Sinha. NAHCON conference. NAHCON is actually yesterday it was very nice, and today also is going to rock. I'm inviting Dr. Sangeeta Pankaj, MS, PhD, Professor and HOD Gynecology, Oncology, State Cancer Institute, IGIMS, Patna. Dr. Sangeeta Pankaj.
Thank you very much, ma'am. A very good morning to all.
कोई आया नहीं.
A very good morning. At the outset, I would like to thank Dr. Supriya and all the organizing scientific committee for giving me this opportunity to present. As this is adolescent gynecologic conference, so I thought that this topic I should discuss because this is very unimportant but very important topic. क्योंकि when young girls come, we don't think that इनको छोटा tumor है, बड़ा tumor है, कुछ malignancy भी हो सकता है. So we are in a lot of dilemma. What should be done to these girls? So ovarian tumor in children and adolescent girls form an uncommon but important part of gynecological malignancies because when they present, they are a source of much anxiety even to the patients and their families, as management of these tumors will affect the fertility of these girls. And these are the ovarian tumors are the most common neoplasm affecting the reproductive system in adolescents, and they are rarely diagnosed in childhood and adolescents with an estimated incidence of 2.6 per 1 lakh girls per year. And approximately 10 to 30% of all the ovarian masses which are detected in girls up to 17 years are malignant. So this is very strange. We do not think that the young girls may have malignant tumors, accounting for 1% of all the childhood malignancies and 8% of all abdominal tumors in children. And adnexal masses in this age group may present in various ways like pain abdomen, lump abdomen, all abdominal distension. So we will think कि maybe इसका menstrual period शुरू हो रहा है और she has eaten some junk food due to this symptom has. And I tell you all the ovarian tumors, why they present, it is a silent killer. It is known as silent killer because there is no symptom. डिस्टेंशन ब्लोटिंग, तो हम लोग सोचते हैं कि पीरियड्स की वजह से है, कुछ भी, बिकॉज इवन द वेरी एजुकेटेड पीपल डोंट कम टू अस इन अर्ली स्टेजेस, तो because the symptoms are very vague. So we all know the classification of tumors, we will not go. Our experience at present, just on Friday we had operated a young girl. She had sarcoma of uterus. When we opened, there was around 3 liters of blood inside. We could not imagine that a young girl of 18 years will have sarcoma. And at present we are having 4 young girls in our OPD, in our ward, sorry. And in the last 3 years, we have operated 40 cases of ovarian tumors, of which 45% were malignant and 55% were benign. Immature teratoma, which was the most common of malignant type, followed by dysgerminoma, and epithelial cystadenomas was most common benign ovarian tumor. So this is the histopathology of tumors, which we have operated in the last 3 years. And you see, most of the benign tumors are more bigger in size. And laparoscopic surgery was done for 14 girls, and open was done in 7 benign and 19 malignant cases. And complete surgery was done in 7. We had to sacrifice our uterus and both the ovaries. And fertility sparing surgery was done in 21 cases. And in malignant disease, 12 cases fertility sparing surgery was done. And mostly they present in stage 3. What I told, because of the vague symptoms, they don't present to us early. So what is the histological distribution? 85% of all the pre-adolescent malignant ovarian masses are germ cell tumors, we all know this. And only 8% will be epithelial carcinoma, but if they present to us, it is very deadly. And 5% are sex cord stromal tumors and steroid tumors, and less than 1% are small cell carcinomas. So what are the general principles of management? When the young girl comes to us, what we should do? So first of all, we should think that are we able to diagnose early, because time is very crucial and very precious in ovarian tumor patients. So you can refer to specialized centers which has a multidisciplinary team, including adult and pediatric experts of oncologists, and therapy should be adequately monitored and by trained oncologists, and staging has to be done according to FIGO 2014 system. In preoperative workup, abdominal and pelvic ultrasound, which is a basic which everyone can afford, it should be done. When we get reports that there is a solid cystic mass, we can go for abdominal pelvic MRI, and thoracic CT should be done to rule out metastatic diseases. Tumor markers, apart from general tumor markers which you do, serum alpha fetoprotein, beta HCG, inhibin, AMH and LDH should definitely be done. The abdominal and pelvic MRI is preferred to CT scan whenever to reduce the radiation exposure, because these are young girls and we have to save their fertility. And preoperative MRI is helpful to assess the potential bilateral ovarian involvement and for better characterization of mass to guide the surgical strategy, how we have to approach laparoscopic or open. So PET CT is not at all indicated, किसी के कहने पे भी नहीं करना है, and we have to avoid doing FNAC कि इसका biopsy करा के देखते हैं, FNAC करा के देखते हैं, तो it will spread. तो in those cases जब पहले ही वहाँ पे ascites है, the capsule has ruptured, in those cases only we get an FNAC or biopsy done so that we can start chemotherapy. Otherwise we avoid doing this. So for management, the surgical approach should be careful selection on the basis of initial imaging, what we have done, to avoid intraoperative rupture of tumor. हमने lab डाल दिया and we could not assess, so intraoperative rupture has to be avoided at all cost, and oophorectomy should be preferred over cystectomy. अगर लग रहा है कि छोटा सा cyst है, इसको आधा निकाले पूरा निकाले, तो be careful, आप पूरा निकाल दीजिए. That is on safer side. And biopsies of the tumors are contraindicated except in patients where there is extra ovarian spread, as I told. And median laparotomy is the preferred option. कभी भी आप सस्पेक्ट कर रहे हैं तो फेनेस्टिल इंसिजन नहीं देना है, क्योंकि अगर आप मीडियन रहेंगे तो यू कैन गो अप टू ज़िफिस्टर्नम एंड यू कैन विजुअलाइज ऑल द ऑर्गन्स प्रॉपर्ली. सो वेन एवर इन डाउट यू गो फॉर अ मीडियन laparatomy. So minimal invasive approach, laparoscopy, should it be done, not be done? When? If you are a trained surgeon in laparoscopy, definitely you can go, at least you can see and then plan accordingly. And if you are able to remove the tumor without rupturing it, and no morcellation has to be done. This you have to be very careful, and full peritoneal exploration has to be done. Laparoscopically, it is done in a better way. We can see everywhere, the liver to POD, everything we can see. So what we have to do in staging laparotomy, if there is ascites, just take out the ascitic fluid. If there is no ascites, then you just take the washings. It is very important in any case. आपको malignant लग रहा है या नहीं लग रहा है, we have to take the peritoneal washings for the safer side and for future treatment. An examination of the peritoneal surfaces, biopsy of the diaphragmatic peritoneum, paracolic gutters, pelvic peritoneum, and palpation of the pelvic and para-aortic nodes जरूर करिए, even if you want to remove or not. And excision of all the enlarged lymph nodes. Regular lymphadenectomy has not to be done, only the enlarged lymph nodes. Inspection, palpation and large biopsy of the omentum is, if it is normal, and removal of the adherent जो lump tumor के ऊपर जो omentum निकला हुआ है, कम से कम at least you have to remove all that. And inspection of contralateral ovary with biopsy of abnormal appearing areas. Fertility sparing surgery should be the first surgical option because all these patients are very young. And in case of macroscopic disease जो बाहर दिख रहा है and spread, it should be clearly documented. आपको लिखना है कि हाँ यहाँ पे है, ताकि जो कीमो देंगे वो लोग उसको कर सकें. जो भी हमारा इंट्रा फाइंडिंग होता है, जो कॉम्प्लिकेशन होता है, it should always be documented for further management. Oncofertility counseling has to be offered in all adolescents and young adult patients before starting any therapy. Psycho-oncological support has to be offered to all patients and their relative at each step of initial treatment and all during follow-up. If the tumor markers are elevated at diagnosis, they should be measured after surgery and before starting of the chemotherapy or follow-up. In case of chemotherapy, the tumor markers should be measured before each cycle. जब भी chemo देते हैं हम लोग उसके पहले करा लेते हैं. These are the malignant of I will discuss some of these. These are pictures of our cases. So we all know that the germ cell tumors all are malignant except mature teratoma. And when we do the tumor markers, dysgerminoma, generally we will get low HCG, and in mixed germ cell tumor, all will be raised. So how to manage the early cases? The presence of a solid or partially solid ovarian mass on ultrasound and an additional MRI should be done in if you suspect that malignant ovarian tumors are there, germ cell tumors. If a solid component is present, surgery should be the initial treatment. In any ovarian carcinoma, it is a principle that we prefer surgery so that the tumor is debulked. In case of bilateral tumors, bilateral self-oophorectomy is strongly discouraged because we have to see for a fertility also, and we should try to preserve at least one. And in cases of solid unilateral tumor, en bloc oophorectomy is the treatment of choice. In cystic tumors, please avoid cystectomy, try to remove the whole. And in contralateral macroscopically normal ovary and negative imaging, biopsy is not necessary. कि लग रहा है थोड़ा बड़ा है तो काट के देख ले, leave it like that. In case of macroscopic bilateral ovarian disease, mainly dysgerminoma, preservation of at least one healthy part or of one ovary should be encouraged until we know that it is dysgenetic gonads. And for dysgenetic gonads, removal of the remaining ovary is encouraged. In bilateral tumors, genetic analysis for sex chromosomal aberration should be done because of the risk of gonadoblastoma and dysgerminoma. And in cases of dysgenetic gonads, bilateral salpingo-oophorectomy can be performed. After you have done initial cystectomy or tumorectomy, then with no indication for adjuvant treatment on the basis of final histopathology report जो आपको मिला है and tumor markers जो है if they are normal, additional surgery की हाँ चलो उसने किया है आपने भेजा है तो I will not repeat that surgery again, ठीक है? And when adjuvant medical treatment is required, तो भी हम लोग को अवॉइड करना चाहिए क्योंकि एडजुवेंट तो दे ही रहे हैं तो वाई टू सब्जेक्ट द पेशेंट फॉर एडिशनल सर्जरी. एंड फॉर dysgerminoma and teratoma, there is risk of bilateral involvement and post-operative ultrasonic monitoring and the remaining ovary is recommended. And where the risk of malignancy is low, या हम लोग को पता नहीं है, तो minimal robotic या laparoscopy we can do. And if the diagnosis is made post-operatively, जैसे बहुत बार पता नहीं चलता, लगता है simple ovarian cyst है, तो we just remove. तो surgical staging उसके बाद फिर भी avoid करना चाहिए. We have to look for the other options. and nodal removal should be done only where there is evidence of nodal abnormalities during surgical exploration or या PET या CT में हमको कुछ बड़ा दिखाया तो. When to give adjuvant therapy? If it is stage 1, just keep her on surveillance, follow up. And stage 1, and if the patient is non-compliant, आपको लगता है कि she will not come back, so we can consider for 2 cycles. And for stage 1B, we have to see the histologic type. कौन सा histology है, then we'll decide the chemotherapy. Chemotherapy में we generally give bleomycin, etoposide and cisplatin or paclitaxel, ifosfamide and cisplatin. In stage 1C, chemotherapy can be given for 2 cycles, and in stage 1C2 and 1C3, इसमें we have to give for at least 3 cycles. In advanced disease, fertility sparing should be considered even in cases of advanced stages because of high chemosensitivity, because these tumors are very chemosensitive. And surgical resection is only required if the residual, after chemotherapy, there is residual disease. And a careful close surveillance should be discussed with patients for dysgerminoma with minimal residual disease on imaging, क्योंकि बहुत बार artifact भी दिखते हैं हमको, and treatment of these should be usually non-viable. Standard chemotherapy for stage 3 and 4, again we give bleomycin, etoposide and platinum for 3 to 4 cycles. अगर जिनका ट्यूमर मार्कर्स रेज्ड है उसके बाद भी एट प्रेजेंटेशन और जिन लोगों का 4 साइकिल्स के बाद भी नहीं नेगेटिव हो रहा है, दीज आर कंसिडर्ड नॉन रिस्पॉन्डर्स टू ट्रीटमेंट. And patients with raised tumor markers at presentation in whom markers are not falling according to their expected half-life after the second cycle of treatment. इसलिए हम लोग हर साइकिल के बाद पहले कीमो कर लेते हैं, मतलब पहले सारा ट्यूमर मार्कर कर लेते हैं. And this should be considered at high risk, and intensification of therapy should be discussed. In cases of immature teratoma with extravariant disease that comprises of gliomatosis peritoni, you must have come across this disease or entity also sometimes. Complete surgical resection of the peritoneal disease is not required. Not necessary that हम सारा peritoneum उसका निकाल दें. However, large and multiple biopsies should be done to ensure that all tissues are mature and glial. And sometimes हमने सारा treatment किया फिर भी disease रह गया. Management of refractory or recurrent disease. For this we need multidisciplinary team approach. एक एंटिटी है ग्रोइंग टेराटोमा सिंड्रोम, आपने ट्रीटमेंट कर दिया बट स्टिल टेराटोमा इज देयर. इन केसेस ऑफ इमेच्योर टेराटोमा और मिक्स्ड ट्यूमर्स with component of immature teratoma and subsequent recurrent and normal serum markers following chemotherapy, presence of exclusively mature elements in extravariant sites, they may be present. Treatment is conservative surgical resection and preserving the uterus and a part of one ovary if feasible. A biopsy is essential to have histological confirmation of the recurrence before starting additional treatment. We had a case, she was a 9 years old girl, she came presented with ascites and 13 centimeter solid cystic ovarian mass with raised alpha fetoprotein, beta HCG and LDH and neoplastic fever with bilateral gross hydronephrosis. On biopsy, it suggested immature teratoma. She received 3 cycles of chemotherapy, interval debulking was done. We had to sacrifice a uterus, TAH, BSO, total lumpectomy, pelvic and para-aortic lymph node sampling had to be done. So the final histopathology reported that there were mature components and now the hydronephrosis has relieved and she is on follow-up. She was only 9 years, but we have 8 years, 9 years, at least this year we are having, every month we are having 2 to 3 cases we are operating, under 12. So there is no definitive treatment strategies for patient who relapsed after completion of chemotherapy. Treatment option has to be considered and can include platinum-based combination and should be taken into account for the previous lines of therapy and the delay between the initial tumor and relapse. इसलिए patient को जब pathology आ गया है तो she has to take the chemotherapy within 3 weeks. अगर वो delay करेगी तो again recurrence will come. In pure dysgerminomas, radiotherapy could also be discussed. And intensified chemotherapy with stem cell support can be considered, and role of salvage surgery in recurrent disease is not defined. So we have to keep her on follow-up every 2 months, then every 3 months and every 6 months and after till 10th year. Something about sex cord stromal tumors, this is also not uncommon. We have to do all the serum markers. IHC has to be done to confirm, and patients should be screened for other Dicer syndrome also, and endometrial sampling is recommended in adult patients with granulosa cell tumor. In early stage, comprehensive staging has to be done with systemic lymph node dissection, which is not recommended. In stage 1A, we have to observe. Stage 1C, observation. Stage 1C2 and 1C3, we have to go for chemotherapy. Chemotherapy is usually recommended, and the same we use, same drugs are used. If cisplatin is contraindicated, carboplatin is used, and management of for refractive and recurrent disease, again, it will depend on the site of treatment, and resurgery for maximum cytoreduction is the best option for recurrent disease, and so we have to follow again for 10 years. Thank you.
Thank you, ma'am. May I request our chairperson to please invite the next speaker?
कर लेंगे अच्छा ठीक है
Thank you, Dr. Sangeeta Pankaj. It was a vivid and very nice presentation. And what we could gather was that recurrent disease has no definitive mode of treatment, and surgery is to be avoided in recurrent diseases. Thank you.
Now our next speaker is Dr. Nibha Mohan, and she's joint organizing secretary of this conference also. So I leave to the chairperson to introduce her.
Dr. Nibha Mohan, MBBA. आइए बोलिए Dr. Nibha Mohan, MBBS, MS, FICOG, CIMP, Consultant, Renu Maternity Center, Patna.
We are saving on time. So we don't
No,
need
thank
to
you.
CV part.
Thank you, Chairperson.
Treasurer Patna Ops Gynae Society, Member Adolescent Health Committee FOGSI, Joint Secretary Patna Ops Gynae Society, Clinical Secretary Patna Ops and Gynae Society.
Thank you. Okay, okay. So good morning, everyone. Respected chairpersons, respected seniors, and dear friends. This morning, I have been given topic to talk upon premenstrual syndromes and its management. So next 12 to 15 minutes, I'll be talking on this topic. The details will be its introduction, its pathophysiology, its symptoms, its diagnosis, its management, including all non-pharmacological treatment, and psychological and behavioral interventions. So, we all know premenstrual syndrome is a cyclical phenomenon occurring during the late luteal phase of the menstrual cycle, characterized by physical, emotional, psychological symptoms of varying severity. It starts a few days or a week before the onset of menstruation and ends after the end of menstruation, onset of menstruation. And the severe form of PMS is known as premenstrual syndrome dysphoric disorder, that is PMDD. This is one of the commonest menstrual disorder affecting young women. Mostly, usually 75% are from PMS problems, and 3 to 8% from severe symptoms of PMS, that is PMDD. The prevalence varies in different countries. In India, it's about 15 to 75% is reported with different studies. So why it happens? Different factors are responsible, mostly the hormone fluctuations, genetics, increased levels of inflammatory parameters, neurosteroids fluctuation, and neurotransmitter disturbances. So mainly the hormonal changes that occur in premenstrual syndrome is the rapid change of progesterone and estriol levels, which rise in the first phase of luteal phase, and it falls so rapidly. And the sensitivity to this rapid increase and fall, especially estrogen and progesterone, is due to genetic susceptibility. In luteal phase of menstrual cycle, there is a high level of progesterone, and its metabolite, one of its, the important is allopregnanolol. In healthy individual, this allopregnanolol has anxiolytic sedative effect, which results in unaffected mood. whereas in premenstrual syndrome cases, it acts in opposite way, that is, it increased inflammation and anxiety and premenstrual symptoms develops. Similarly, there is antioxidant activity of progesterone and estrogen in healthy women, whereas in PMS cases, due to improper or increased pro-oxidative activity, there is neuronal damage, membrane damage, which leads to PMS symptoms. Another source of oxidative damage in the neuronal membrane is catechol estrogen, which produces oxygen radicals. So the symptoms we could divide in physical symptoms and emotional symptoms. Physical, we all know it's all disturbance of all the symptoms like swelling, tenderness, bloating up, feeling, constipation, diarrhea, cramping, headache or backache, clumsiness, lower tolerance for noisy or noise or light, and various emotional symptoms as well. Irritability or hostile behavior, feeling so tired, sleepy problem, appetite changes, trouble with concentration, tension or anxiety, depression feeling or sadness, mood swings. These are the normal PMS symptoms, and the severe ones, which we call as premenstrual dysphoric disorder, that is PMDD. The symptoms are much aggravated. So symptoms of PMDD that include severe headache, joint and muscle pain, overeating and sleeping problems, feeling very anxious, angry, and sometimes suicidal tendency as well. So we have American College of Obstetrician and Gynecologist criteria to diagnose premenstrual syndrome. As we all know, so many vague symptoms are there, so they have defined very clearly that these symptoms should be diagnosed if the patient reports at least one of the following symptoms, either effective, ineffective group and somatic group. They should appear few days before the onset of menstruation, and this is relieved within 4 days of onset of mens without recurrence until at least 13 days in the cycle, and must be present in absence of any drugs, hormone ingestion, or alcohol use. And this should happen in at least 3 previous menstrual cycle. Then we can say that yes, this is going to be a PMS only. The symptoms, as we have just discussed, affective symptoms are angry outburst, anxiety, confusion, depression, irritability, and social withdrawal. And somatic symptoms, abdominal bloating, breast tenderness, headache, joint or muscle pain, swelling of extremities, and weight gain. So we can exactly or thoroughly diagnose the PMS this way. So what are the treatments? We all are treating PMS in every day in OPD. So we can divide it in psychological and behavioral interventions, non-pharmacological treatment, and pharmacological treatment. So non-pharmacological treatment, we should say it's should be the first line of treatment, lifestyle modification. As we all know in adolescent group, what lifestyle they are having these days. So they all know what is the better, but we must counsel very strongly that they should have a very healthy lifestyle with their dietary changes. They should have a balanced diet. They should have reduced caffeine and sugar, which exacerbate the symptoms. They should cut down sugar, and they should limit their salt intake. And stress management is very useful, because most of the time these adolescents are under stress, either of their studies, of their business, of their marital or their premarital status. So they should be very strongly counseled about this stress management. Relaxation technique could be either yoga, meditation, or deep breathing exercise. And in this way, their stress should be managed. And exercise is also very important. They should have a very regular physical activity that could be either walking, swimming, or cycling, whatever of their interest. This reduces symptoms like fatigue, depression, and irritability as well. Sleep hygiene is also very important, because most of the time they are doing night studies or night duty, and their sleep is during daytime only, and that is also not proper. So they should aim 7 to 9 hours of sleep per night. Herbal remedies is the time-tested remedy of our country. So it still goes on. This helps balance hormones and reduces symptoms like breast tenderness, irritability, and mood swings. Some are still there, and some of them are we are using as well. Chasteberry may help reduce PMS symptoms by balancing hormones. Evening primosol we are using every day. I mean, most of the patients with breast tenderness. There is another ginkgo biloba, 80 milligram twice daily, helps reduce breast tenderness and fluid retention in these patients. Pharmacological treatments, yes, and NSAIDs most commonly used because we all know that it produces prostaglandin, and this reduces inflammation, and then by this we can reduce cramps, headaches, and breast tenderness associated with PMS. The commonly used one are ibuprofen, aspirin. This also reduces cramps, headaches, and breast tenderness as well. Hormonal treatment is also very commonly used. Most commonly is oral contraceptives, which regulate hormone fluctuations, which is the main responsible factor for this PMS symptoms. So they can reduce the severity of physical symptoms and mood swings as well. Then progesterone and progestins are also used. They have also very good effect. And gonadotropin releasing hormone is the last, very rarely used, but can be used in very extreme cases. But we all know it has limitations, cannot be used for longer time, and it has many side effects as well. Then we have serotonergic antidepressants. So SSRIs are first line of treatment for those patients who have psychotic problems. So in that cases, this is the first line of treatment. So we have many products with sertraline, paroxetine, and fluoxetine as well. All SSRIs doses seem to be effective for psychiatric symptoms and ultimately could be titrated to the patient's tolerability. But we have to remember that when we are going with this group, then this takes few months, at least 2-3 months, to give the best results. So this has to be explained to the patient. And higher doses are needed for the relief of physical symptoms, which we usually don't do. SNRIs are also very effective. Then sometimes anxiolytics have to be used, benzodiazepines, alprazolam. This is a short-term treatment for very severe anxiety or insomnia. This you can be used, and usually we have to use sometimes when these young patients are really very bad with insomnia problem. They are typically not used for long term, as there is dependence with this drug. Then there are some supplements and vitamins like calcium can reduce the severity of PMS symptoms, including mood swings. So 1,000 to 1,200 milligram per day has been shown to reduce PMS symptoms. Then vitamin B6 also has a very important role for neurotransmitter production. So 50 to 100 milligram per day can reduce the symptoms. Antipsychotics are needed in extreme cases of psychotic patients, and usually we don't do it, and we refer for such patients. And doses are typically lower than those used for treating psychotic disorders. And we have to modulate dopamine and serotonin receptors in the brain, which can stabilize mood and reduce severe mood swings and anxiety associated with PMS and PMDD as well. Psychological and behavioral interventions is really good, and this is much needed for the young girls, adolescents, and all young patients. Cognitive behavior therapy helps them a lot. This can help manage mood swings and anxiety by changing negative thought patterns and behavior. So we have to do this with the professional ones also, and we can make them a part of the group of supportive group, which we call, and those patients who are suffering with the same problems. If you are in OPD, you have 3-4 patients, you can make a group and you can make them join that group so that they can know that these are the common problems and get solved also. So we should give them a positive feelings of this problem, that this is a physiological problem and goes away easily with all those natural therapy as we mentioned. And they should be monitored, should be monitored by using their monitoring diary, like they should take track of symptoms every month, like when is it increasing, why, with which factors it's increasing, and they should be under regular checkup. So to sum up this topic, we have premenstrual syndrome, which involves a range of physical and emotional symptoms occurring before menstruation. Management includes lifestyle changes like a balanced diet, regular exercise, along with stress reduction techniques, all yoga and meditation included. NSAIDs and hormonal treatments can help alleviate severe symptoms. Alternative therapies like supplements, herbs, and remedies may also provide relief. Thank you so much. And this is just a request to everyone who are going to vote me for this post, Food and Drug Committee Chairperson. Thank you so much.
Well explained, Nivadi. You have covered all the things and in a nice manner. Today in day-to-day life, we are getting lot of cases, young adolescent girls, and we are facing lot of problem. But mainly we have to counseling. Counseling is more important and regarding their mental health and their day-to-day lifestyle. Thank you, Nivadi.
Thank you, Dr. Nima Mohandi. And it was a very nice and vivid presentation. And one thing I could, although it's very common in adolescents, still the most neglected topic of by the obstetricians. And it was a revision for us. Thank you, Nivadi.
May I request the chairperson to please invite the next speaker? Her CV has already been displayed.
Now we welcome Dr. Sujata there, MSFI COG, Professor Unit Head of Department of Obstetrics and Gynae, KG Medical College, University, Lucknow. Welcome.
A very good morning to all of you. And outset, I would like to thanks to Dr. Supriya and her team to organize so wonderful adolescent conference, because it is quite difficult to manage, but she organized very well. So once congratulate to them, also to all the team which are doing the wonderful job. And today is my topic is the mental health, need to care for the adolescent health. As we know that mental health is a state of the mental well-being that enable people to cope with the stress of the life, realize their ability, learn well and work well. So if we see that how much is the adolescent in our population, it is near about the 1/4 of the total population. If in worldwide, it is estimated that 10 to 20% of the adolescents, they experience mental health conditions. And if we see in India, the prevalence of the psychiatric disorder is around 7.3. And we all, not only the adolescent, in the younger age group and the adolescent phase, we realize and feel sometimes that depression, anxiety and all these things. So it has been said that 50% of the, if the adult is suffering from the psychiatric disorder, that has been started before the 14 years. Now the rising of the mental health issue, why they are so rising? Because of the single family, single parents, no family support, increasing use of the media and all these digital platform that is present. And WHO also experienced that 20% of the adolescent having the mental health problem at any year. So it is very, very important to think about this. Major psychotic illness by which they are suffering. Most common is the anxiety, depressive disorder, behavioral changes, and not at this level sometime to the up to the suicide. And it has been found that fourth main cause of the death in the adolescent is the suicide. That is very, very important to think about. What are the challenges to manage them because of the lack of the education and awareness of mental health in this community? And still there is the stigma in the community for the mental health. And so it is very important. But first we should think and should know what are the causes, why it is more prevalent in the adolescent age group, because not only the anatomical physiological changes but also some there other psychological changes is occurring. As we all know that during the adolescent, hormonal changes occurring, physical changes occurring, and psychological change is occurring. And in this, two change are very, very important. That is the brain development and the hormonal changes. What happened in the brain? That is the, if we see in this, that the neurons are made in the blue and the some synaptic neurons, and there is the synaptic पर्निंग ऑफ द न्यूरॉन्स अकर, मतलब कि जो छोटे न्यूरॉन्स का फुली डेवलपमेंट नहीं होता. सो अप्स एंड डाउन ऑफ द बिहेवियर दैट्स अकर, एंड sometimes they are very irritable, sometimes they are very sad, sometimes they are very feel alone. So this could be. And the another one very important, that is the hormonal changes both in boy and the girls, and these leads as the sometime affect and impact on their mood and the behavioral changes. So you can see the teenage brain, how many lobes are working of the different aspect, and how they sustain all these things to manage themselves simultaneously. Beside that, the another perspective is very important, that is the psychological, in which he or she feel the feeling of the autonomy, feeling of the privacy. Sometimes there is the parental conflict, body changes, and the adjustment issue, and the most important, the influence of the newer technology, and most important, the peer pressure, that is very, very important. So there are the very unique changes occur in the adolescent age group. Adolescent as reaches the puberty, significant change in the boy and female both are occurred, and that can affect the mood, energy level, and the overall mental health. In the female, when the puberty started, menarche started, menstruation started, there are the many problems related to this, early and unprotected sex and consequences. And beside that, the another few obesity, PCOD, that can also have the some component. Starting of the menstruation, onset of the menstruation is one very important challenge in the, especially in the girls. So it has a lot of the related problems, not only the physiological, but sometimes heavy menstrual bleeding, dysmenorrhea, irregular menstrual cycle is also considered there. Early and unprotected sex, because of the lack of the knowledge of the sexual changes and the onset of the sexual activity, sometimes due to the inability to access contraceptive and self-services, lead various risks and the consequences, not only the not only the mental but simultaneously medical, social, and the economic, that also the one cause of the mental health. Body image and the self-esteem issue. Does the eating disorder can also affect? Definitely, as obesity is one very important, and sometimes the adolescents are under pressure of the ultra thin due to the impact of the media, as one set of the example that has been given by the Kareena Kapoor, that was the zero figure. So most of the girls, they want and leave the food and all this, the bulimia, anorexia, and obesity is one very, very important, because not only the look but also having the PCOS, and that can be the lead as the one major cause of the mental health. Body shaming, कोई काला है, कोई गोरा है, कोई टकला है, a lot of the film issue made on these issue, that again very important, because it negative for the body image give a very, very insecurity to the people, and sometimes due to this they feel very loneliness, feel very low esteem, anxiety, depression. Sometimes they do the self-harm to up to the suicide. And peer pressure, because to desire to fit and accepted by the peer is strong during the adolescent health. So sometimes it can lead to the risky behavior, such as the substance use or unhealthy eating habits, and affecting both physical and the mental health. ये तो हम सबके लिए बहुत important है, because sometimes this has to be given by the parents and family also, academic and the extracurricular stress that is very, very important in this. feeling and the process of the forming their identities, seeking independence, and this lead the conflict to the parents' authority, and sometimes that cause the emotional stress. Impact of the technology and social media, constant connectivity, it leads not only the improper sleep, self-esteem, rather than sometimes they exposed to cyberbullying and online harassment that gives a negative impact on the mental health. We all know that sometimes the adolescents have real problem, but due to the mental health stigma that is still in the society, they are not able to seek help proper to the service provider. So what are the common mental now till now you understand that anxiety and depression, one very important. Beside that, if we go in the psychiatric illness, body dysmorphic disorders, self-harm, suicidal tendencies are very important. So we all know that prevention is better than cure, and the aspect of the obstetrician and gynecologist is on this, because we can prevent by the counseling, by the education, and we should give the proper information about the physical and the hormonal changes what they experiencing during this phase, and we have to be organize the workshop seminar to give the proper awareness information about them. And sometimes we can do the online resource that can we also provide to them. Always ask them to choose the healthy lifestyle, balanced diet, regular exercises, group activities, and avoid the junk food, especially the excess sugar and the caffeine, because ज़्यादातर जो एडोलिसेंट है वो बहुत इसको लाइक करते हैं. सो स्ट्रेस मैनेजमेंट टेक्निक दैट शुड बी, we should ask them to have not only in their routine but also in the school activities, that should be mindfulness and meditation. And meditation, that breathing exercises, all are very important for the adolescent to reduce the anxiety and the depression. Adequate sleep. We don't, जब हम young थे तब हमें पता भी नहीं होता था कि what is the sleep hygiene, but now this term is come in very commonly in our curriculum, that is the sleep hygiene, that educate them to have the good sleep. And because good sleep is very important to restful sleep environment, and before that important that they should limit the screen time of the either by the mobile or the laptop or any media that have to be encountered then. And the important, whenever they have any problem, we should always counsel them that we are there, family support. So in difficult situation, at least they feel somebody is there in behind me that can be support. Addressing, sometimes they have the specific issue like the menstrual health, so need of the counseling, any reproductive and the sexual problems, that we have to be youth friendly health services by the healthcare workers who have been trained. We should not be judgmental to them. Comprehensive sexuality education at the school and the college level, and free access of the contraceptive and the safe abortion services should be provided to them. And if there is need of sometime, if they have diagnosed any case, any problems, then early intervention is very important, because it can prevent long-term negative consequences that can be occur. So in this field, the WHO is very actively working. They develop a module on the child and the adolescent mental and the behavioral disorder as part of the MH-GAP intervention guideline. And this is the latest guideline, and it provides the clinical protocol for the assessment and the management of a range of the mental health condition in a non-specialized care. And it has a long question on the base of that include the depression, psychosis, self-harm, suicide, dementia, and all other the factors that has to related to the mental health disorder. Not only, they also make the HET guidance that has have the recommendation on the promotive and the preventive psychological intervention for the adolescent is 10 to 19 year, that which can be implemented. We have to be say that it should be implemented in the school health setting and communities or the through the digital platform. So if required the treatment, we can give the biological therapy, psychotherapies, family therapies, and refer to the adolescent to the psychiatric also in the within time and in time. So child and adolescent mental health is not only the single person individual, but it has the responsibility of the family. Responsibility always, it should be shared between the different stakeholder, and it is very important need of the expansion of the awareness in the community, and we have to be implement the promotive, preventive, and curative services so that we can restore the adolescent mental health in their life. Thank you.
A very nice presentation, Dr. Sujata. Wonderful. Yes, you're right. Early intervention is very important. And if that is taken care of, I think a lot of problems will be taken care of. Thank you.
Check.
Well presented. Your presentation was very nice. And in day-to-day practice, we need all of these things. And at the outset, we can say, healthy adolescent, we will get healthy adult.
Yes.
All
Thank you. Thank you, Manoj.
All right, thank you so much, ladies and gentlemen. May I request all our speakers, that's Dr. Sangeeta Pankaj, Dr. Nibha Mohan, and Dr. Sujata Dev, to please join us here. I also request all our chairpersons to please join us this side of the stage. Ma'am, all the chairpersons this side, we would like you to felicitate the speakers. May I request all the speakers, please come in. I also invite our convener, Dr. Sukruti Singh, and also our coordinator, Dr. Zarina Rahman. And we'd like to fill it. Meanwhile, ladies and gentlemen, let's go ahead with the next session where we have the panel discussion. All right, so for the next panel discussion, I would like to invite our moderator, Dr. Sneha Bhuyer, on the stage, please. Dr. Sneha Bhuyer, a warm welcome to you, ma'am. I would like to invite our expert, Dr. Priyankur Roy. All right, I would like to invite our panelists, Dr. Kalpana Singh, Dr. Rajrani Chaudhary, Dr. Prabhati Kesari, Dr. Sunita Sharma, Dr. Ranjana Jha, Dr. Veena Sinha, Dr. Chanchal Sujata, Dr. Sangeeta Singh, and Dr. Sashi Bala.
So, a very good morning to all of you. No, Priyankur has left already. He conveyed me. A very good morning to all of you. At the outset, let me thank the organizers for having me here, especially our dear friend, Dr. Supriya Jaiswal, the entire team of Patna, especially Dr. Meena Samant and Dr. Amita Sinha, and the entire team of Patna. I would say Madam Zareen and so many seniors. Patna is like my own society. This is the 4th time I'm coming here as a faculty. So friends, without much ado, I think we would straightway go ahead with the subject for today's discussion. All of you know that polycystic ovarian syndrome is the commonest endocrinological disorders we all face in day-to-day practice. It is so common that it involves, all the age group, right from adolescence. It continues throughout the reproductive period and also the perimenopausal age group. The incidence, of course, varies a lot. May it be rural or urban, you can say nowadays. 1 out of 10 girls from the rural population and 2 out of 10 girls from the urban population, they face this issue. We don't know whether this is the etiology or the manifestation of the other endocrinological disorders, but definitely environmental factors, the changing lifestyle, the eating, unhealthy eating habits, the sedentary lifestyle, of course, the genetic factors, persistence of physiological hyperinsulinemia of childhood. A lot of you know this is a change during the transition period. And though it starts as a disease of adolescence, it continues throughout. It's not the disease for that particular period, but it has got manifestations which affect the entire life, and that is why we are here to discuss the PCOS spectrum. So with this, I start with the first case, and we start from the that end of the panel. So we have this 13-year-old girl who reports with her mother to the gynecologist. The mother is very apprehensive because of her irregular cycles, and she's only 9 months post-menarche. The cycles are 4 to 5 days every 20 to 60 days. Her BMI is 24, and she's got mild acne on the face.
Hello.
There's no other medical or surgical problems, and she has come to you with the ultrasound report saying that she's got PCOS, multiple follicles in both the ovaries, and otherwise rest is normal. So she is worried about this. How do you, what is the diagnosis, and how do you convince or counsel the, I would say the mother rather? Yes.
As she is a young girl and she has just achieved her menarche 9 months back only.
Right.
So there is not much of worry about her cycles so
Right.
far, because yet
But her mother
pituitary
is worried about her cycles only, irregular cycles. So
Yeah.
that is what
so
is
we
the
just
question.
have to reassure her that the pituitary hypothalamic axis will take some time to mature. So
Right.
cycles would be irregular.
Okay.
But in case of
But the next question she will ask you, till when do you expect these cycles to be irregular, and when should she
it
start
takes-
getting regular
yeah,
cycles?
usually it takes 2 to 3 years altogether for the cycles. It may take up to 2 to 3 years.
But what is the otherwise normal routine you expect?
Yeah. So and the BMI
For the first year, how much, and for second and third year, how it goes transition? Yeah.
initially
you can pass it on. You can
Yeah,
pass it
yeah.
on, please, for that.
According to the ASHRAE's guideline, in the first year post.
We talk about this practical aspect
so
first.
this
How
is-
do you counsel the mother who is so anxious?
If the periods are occurring every 90 days, in less than 90 days, it is considered normal in the first year after menarche.
Okay.
And after that, if more than 1 year up to less than 3 years, it can be less than 21 years or more than 35
Okay.
35 days.
Okay. Anybody wants to add to this
And-
practical discussion? You can pass it on, please.
60% patient presented irregularly up to 1 year, 30% to 2 year, and then 20% is 1 year irregular cycle.
Okay. Anybody wants to add anything to this?
And ma'am, it also take a 8-year time to take the maturity of axis.
So basically, irregular cycles are, if you have to say that nothing to be worried, because for the first year it's going to be irregular. But if after first year, that is 1 to 3 years, if it is less than 21 days and more than 45 days, the cycles, then you have to label it as irregular. If after 3 years, if it is less than 21 and more than 35 days even, as she rightly said, sometimes more than 90 days, maybe even 8 cycles only for the year. So if that is so, then you have to label this as irregular cycles. So definitely she is only postmenarchal 9 months. So not to worry, that is what. But, and also the hirsutism, the clinical manifestations, they are not very severe. So this is, so now what is your diagnosis, Dr. Kalpana?
Yeah, mild hyperandrogenism or polycystic ovarian morpho is common during adolescence, during physiological changes, and she's just 9 months. So as per the latest diagnostic criteria, she's not a case of PCOS.
Right, she's not a case of PCOS. Then what is she?
She's just, we have to keep her under watch. She is at risk, maybe at risk.
No, not even at risk, because see, the hirsutism also, it is very, very, very mild.
Minimal. Only BMI is high, so lifestyle modification.
That is also normal. Do you expect the girl to put on some weight, especially in the fat of the breast and the buttocks? Okay, I mean, she starts growing and she starts gaining weight. So what this is a normal transition, okay? She is a 13-year-old girl and this is only the normal transition. Suppose any other investigation you want to do for this girl, 13-year-old girl, do you want to do any investigation?
Yeah, thyroid prolactin assessment should be done, can be done.
Right. So if at all, you have to rule out if the other causes, maybe just as a routine, as you said, only the hypothyroidism and maybe the prolactin also you can rule out. So this is what we have already discussed, how the irregular cycles are. So why the diagnosis of PCOS is difficult in adolescence? I have already told you that we have to label this as the normal transition. Okay, it is not even the PCO morphology, not even at risk. Okay, this is the normal transition. So we should know what is normal, then only we can tell them that what is abnormal.
Actually, there is a great deal of overlap in cases of adolescents.
Right.
Because as said by Dr. Kalpana, that the hypothalamic pituitary ovarian axis is maturing and the cycles are irregular at first, and the thing is that for the diagnosis of PCOS, we consider 2 of the 3 criterias in normal women, but in cases of adolescent, the PCOS morphology is not considered as a part of diagnostic workup,
right,
because the ovaries are
yeah, but that we have talked about, that she is not a case of PCOS, so we will not discuss about the criteria.
So this is not, the difficulty arises in diagnosis because we cannot take the ovarian morphology for the diagnosis. We have to...
That we are not supposed to do the ultrasound. So basically why there is a difficulty, because irregular cycles are normal during... See, irregular cycles, oligomenorrhea, anovulation, and then the ultrasound picture. These are the 3 criteria, right? And then of course the biochemical hyperandrogenism. But irregular cycles, as you said, it is normal transition. Then of course mild comedonal acne, and of course mild extra hairiness, that is also normal. So even clinical hyperandrogenism is a part of normal transition. That is why there is a overlap and it's difficult in the diagnosis. So how do you do the diagnosis of PCOS in adolescents?
In cases of PCOS in adolescents, we take 2 criteria, either clinical or biochemical evidence of hyperandrogenism, in which we can have a Ferryman-Galway score for hirsutism,
right,
as well as Ludwig score for alopecia or other things which can happen in cases of acne also. Depending upon the race, the patients may not have hirsutism. In some of the Japanese, they do not have hirsutism, but they have acne, depending upon the level of activity of 5-alpha reductase in the skin.
Right.
So we have to keep an open mind about the clinical features of hyperandrogenism. Along with that, we have to either this or...
the only question I would ask you, whether you will go for ultrasound, because rest we have discussed everything.
In cases of adolescent, we do not go for ultrasound.
Till how long?
But
you can say that. You can pass it on to her.
It is not to diagnose PCOS, but to exclude other conditions.
Right.
We have to take ultrasound. We have
Yes.
to do ultrasound.
But then when? What is the
especially
criteria? What is the guideline?
if there are features of hyperandrogenism, then we have to see what else is there. Is
Right.
it this thing? So adrenals and all these areas, liver,
Right.
pancreas, everything, every other organ has to be seen.
Right.
And biochemical tests is also to be done just to exclude other pathologies.
Right. So as a routine for adolescent, you are not advised to go for ultrasound. It's only 8 years post-menarche or the gynae age of 8 years you are supposed to go for ultrasound. So we have already talked about that this is a case of normal transition of adolescence. I mean, there is no excessive hairiness, there is no hyperandrogenism, which also need to be excluded. So not to even offer her the other investigations. You have to just assure the mother that this is actually a normal transition. She is growing, it's a part of her growth and development. And of course, now that she has come to you, so whether you would like to take this opportunity, it's not only see that girl, then whether she needs a treatment or no. Now that she has come to you, to the girl you can advise about the normal, the healthy diet, active physical exercise. You can advise her about the HPV vaccination. And of course, the mother has come to your clinic. You can advise her about the pap smear mammography, what is necessary for her age. So you have to give the holistic approach. You don't have to be very patient-centered, okay? So we now move ahead with the second case. Now this same girl, she reports at 17 years, okay? She's now in 11th class and she now has frequent cycles. So since last 6 months, she has frequent cycles and she has joined a coaching class. Her flow lasts for 5 days and cycle length varies from 15 to 18 days. She had menarche 5 years back that we have already talked about. She has no acne and hirsutism, excessive weight gain 3 kg in last 2 months. Her BMI is 26 now. Thyroid parameters are normal as you suggested. No clinical evidence of hyperandrogenemia. On investigations, TSH is 4.2, just borderline. Serum prolactin, FSH, LH, testosterone, they are normal. 75 gram 2 hours blood sugar levels are normal. So what is the probable diagnosis? I think we don't have Dr. Prabhati here. Anybody can take up this. And what investigations and how are you going to counsel her? Yeah.
Sir, ma'am, so ma'am, it is also age is 17 year and has a BMI more than 25.
Yeah.
So actually, she is also in transition phase because post-maturity take about 8 years. So it may be obesity. Or it may present with irregular cycle and this, so it may not a typical case of PCOS, but she is a case of obesity or may have a high risk of may develop in PCOS in later age.
So now she is she's not a case of normal transition. She's already 17 years old. Now she has started showing the signs of extra BMI, the increased BMI and hyperandrogenism clinically. She is a case of, PCOS at risk. What advice do you give this to this girl?
Ma'am, first of all, I will advise her to lose weight because weight reduction will...
And before that, I would ask you, any other investigations you would like to go for? I think
also
this side we will
for
have.
blood sugar, OGTT and hyperlipidemia.
But
and thyroid profile, serum
Yeah,
prolactin.
Hyperandrogenism also excludes 17-hydroxyprogesterone. We can do to exclude the late development of congenital adrenal hyperplasia. It may have this type of symptom.
Okay, we'll come to the details of it little later. How will you counsel? Yeah.
History taking physical examination is also important. Hip waist ratio is important. It is
what is the important history here? She's in 11th standard, joined the coaching classes.
First degree family relative is also important. Proper counseling.
She
Okay.
is a 17-year-old. She has just joined coaching classes. We should also ask about, we do not ask the adolescent about whether they have any friendship or not, whether they have any history of
How is it concerned with our discussion?
So because this can be the patient, and she is saying that she is having periods every 15 days. And we should ask whether there was history of amenorrhea or not. We should not take each and every case as to be a case of PCOS. There could be some factors which can lead to the development. Because in the PCOS, in 80 to 90% of the cases, there is hypomenorrhea.
So what we are discussing here, we know that she is a case of PCOS at risk. What we are discussing that how to counsel her, what advice you want to give her.
Counsel,
Please be very quick and crisp. Yeah. You can talk about that.
So she is at risk. So we tell her what are the risks.
You can pass it on the mic to her. About what advice you can give.
I advise to lifestyle modification.
What is lifestyle modification? How will you, how do you talk to your patient? Suppose she is your patient.
I ask for her for food habit and advise to take healthy diet, regular exercise.
Suppose she really wants to know from you how much calories she should take and how should be her spread. How will you tell her?
30 kilocalorie in normal BMI patient is advised.
And if here there is a obesity is present.
If at all, please pass it on fast. We want to be quick because we have to discuss lots of other cases also.
Patient is advised to healthy life, balanced diet, take high protein diet, low glycemic diet, and regular exercise about 30 minutes per day in 24 hours, aerobic exercise, and junk food should be avoided. If she is taking alcohol or any smoking should be avoided.
Yes, so healthy dietary habits, how much calories she should take, that is decided by as per her daily recommended allowance, and how should be her spread. She should totally stop sugar, especially the simple carbs.
And caffeine.
She should take the complex carbohydrates, and the majority part of a diet. If you see the spread of the thali, the 50% of the thali should be full with the non-starchy vegetables, and palm full of proteins, and of course fist full of fats. That is how it should be the healthy. And about the exercise, you said how should she go for the exercises? How much time, how frequently?
Ma'am, she should do at least 60 minutes of exercise per day, and preferably 60 minutes per day according to the recent. Ma'am, I'm talking about the international guideline 2023. It's 60 minutes per day for adolescents, and at least 3 days should include, vigorous, stretching and muscle strengthening exercises.
Yeah, what is the most accepted way of doing exercise?
She can do, aerial yoga.
60 minutes, I don't think anybody is doing, but then the moderate exercise of 30 minutes.
Ma'am, this is what recommendation says.
30 minutes, this is what the recommendations are saying.
Ma'am, slowly patient is considered to not do the extensive exercise initial part, slowly improve the time of exercise.
Yeah, that
and
is
even
okay.
5% reduction of weight, normalize the weight and menstrual cycle.
Yes, so at least 30 minutes of moderate exercises that can even include your day-to-day routine activities, stretching exercises, maybe brisk walk and even jogging. Okay, maybe you customize yourself not to use the lifts and elevators, don't use remotes, you modify your lifestyle in such a way that your energy is, utilized. So that is how it should be. 30 minutes per day, 5 days a week, 150 minutes per week. That is what is all the recommendations are saying, and I think most of us follow. It's not only diet modification, what we have said, calorie restriction and the right spread, and then of course active physical exercise. There is evidence that yoga definitely helps, and it has an advantage over the other physical exercise. It says that in the glucose and insulin and lipid metabolism, yoga has got an advantage. Especially it gives you improvement in all this. Of course, proper sleep, especially the midnight 12 to 6 sleep, and of course your routines. psychological supports, these obese, obese girls with acne, hirsutism, they're actually into negativity, so they definitely need some psychological support also. So that is also a part of your treatment. We have already talked about yoga, and we have already talked about this food pyramid. What I have said is maximum of low GI food. I think that needs a separate discussion itself. So with this, we at least have a consensus that she is at risk and she needs the dietary modification and active physical exercise and all the supportive therapies, right? So we move on to the third case now. The same girl presents 10 years later. Now she is 27 years. She has a hectic job profile, working for almost 12 to 14 hours continuously every day. And she followed weight loss. She had regular cycles for few months, but then again she gained weight and her cycles are back to irregular. Now she is having delayed cycles every 50 to 60 days, delayed menses, and with slightly heavy flow. Her BMI has increased to 28. She has developed features of hypoandrogenism and of course terminal hair, upper lip, chin, few hairs present on lower abdomen, back thighs. Acne have also developed significantly and she is conscious about her looks. Now on examination, her hormonal profile is normal. Okay. What will be her management like? Anybody can start now. You want to start?
Weight reduction is very important in this case because her BMI is 28.
What is your diagnosis for this patient?
The patient is suffered from PCOS with metabolic syndromes.
She is now a frank case of PCOS, okay?
Yes.
Okay.
Yes.
So how will you manage?
So proper investigation is necessary, like gas test, glucose tolerance test.
You can start from this end, then pass it on.
So for the management of hyperandrogenism, hirsutism and acne is concerned, we can give her cyproterone acetate, which will manage her.
So basically, she has hyperandrogenism, all the features. She has obesity, insulin resistance, and so these are all the aspects you have to manage, okay?
Yeah.
Irregular cycles also. So how do you manage all the aspects?
Manage by...
You can take my...
There is menstrual irregularity
irregular
also.
cycles, that is what
That's
we said.
why we will manage her with the oral contraceptive pills.
Yeah.
And we will ask her to reduce her weight so that insulin resistance is decreased.
Right. So making her, regularizing her cycles is one way. Okay. What else? You want to add something? We have already said that we have to manage her on all these three aspects.
Lifestyle modification followed by we can give
that we have discussed, no? Weight reduction.
Weight reduction,
Yeah.
combined oral contraceptive.
So I would ask you, no, how to reduce weight, we all have discussed already. How does it help?
So
5% of weight reduction.
Weight reduction, if 5% to 10% of weight reduction is done, that will help in changing the hormonal milieu of the patient, and that will result in the cycles will become more regular. She will have less of hirsutism because the androgens levels also go down.
Right.
And if followed by the blood sugar level, if it is rising in these cases, that also comes down. But if it is not, the exercise is not able to cure all these things, then we go for COC.
Yeah. So now irregular cycles, weight reduction that you have already said. How do you evaluate the hyperandrogenism? You have to know whether it is ovarian hyperandrogenism or the adrenal side or anything else. You can pass it on, please. How do you investigate? What investigations you want to do?
So first we will do serum free and total testosterone, and after that we can also do androstenedione and DHEAS. And if there is a case of virilization, then we should look for the Cushing syndrome or the congenital adrenal hyperplasia.
Yes. So ACTH and ACTH stimulation or dexamethasone suppression to differentiate between the ovarian and adrenal. So you have said that. Now how do you manage this hyperandrogenism? Suppose it is a ovarian hyperandrogenism.
So Ma'am, ovarian hydrogenesis should be taken OCP pills, like which have a anti-androgenic activity, like fourth generation progesterone, like combination of estrogen and dronis 30, like drospirenone can be taken, and also cyproterone acetate combination should be given. That maybe have a lessen the weight loss is also indicated, reduce the androgenic activity and reduce the weight. So this molecule is
correct.
Before that.
Now that this girl has got, very significant hyperandrogenism, she's worried about her looks. So what will you do for that? Because she will say,
some
see,
local
these hormones will take lots of time to work, and
so some local therapy is also advised. Some local therapy is also advised to this. Some ointment or flutaride or some endogenic drugs should be advised.
Meditation and yoga is also advised for this type of patient.
It's better to add, give her metformin also. It will help us in, improving its insulin resistance, madam.
So basically, management of hyperandrogenism, you have to think about the mechanical measures first, because she's worried about the looks. So maybe shaving, using some, electrolysis, laser therapy, all these things, that comes. Dermatological or cosmetic management comes first. We will just finish it up, I think. As all of you have said, that COCs, it will take care of both the things. Regularization of cycles also, androgen also will be lowered. And then, of course, the cyproterone acetate, spironolactone to take care of the peripheral hyperandrogenism. So definitely myoinositors as insulin sensitizers, and even metformin if you are worried about the weight as well, that will help in both ways. So that is how, we have many interesting cases also, but we have to conclude this panel because of want of time. And I thank all the panelists for the interactive discussion, and I thank the organizers again. We have, we have lots of cases also and lots of slides, but because of the time, definitely it's obese PCOS and lean PCOS. Even though she's lean, the management is almost the same, because the presentation is also the same. Of course, the drugs, we are not working on the weight reduction, that's the only aspect for that. So insulin sensitizers definitely have a role, and as the panelists have already said, for obese PCOS, reduction in 5 to 10% of the weight normalizes the menstrual cycles as well as regains the ovulation as well. So with this, we conclude our panel, and it's not only the adolescent problem. Though it starts at adolescence, it can, continue throughout the life, and even the perimenopausal, where we have actually the AUB and endometrial hyperplasia and endometrial cancer and so many other metabolic syndrome. Actually, we have those cases, but we could not discuss it. So we conclude this panel that we have to catch them young and treat at the earliest. And I thank all of you once again. Just a humble appeal from my side that I am contesting for Vice President FOGSI from West Zone, and the voting will start from 1st of August, 1st to 10th. It is online. For West Zone, we have 2 posts. Please do make me as your first choice and vote for me. Thank you so much.
Any question from the audience?
Ma'am, we'll be running out of time, so we'll skip this question answer session.
Thank you, madam.
So I would like to thank all our the experts, the panelists, and special thanks to Sneha ma'am. I request everybody to please come down this side. We are going to felicitate each and every of you, and we have Dr. Priyanka Raj to do the needful. Please join us, all of you. Thank you. Ladies and gentlemen, now going ahead for the next session. First of all, I'd like to invite our chairpersons, Dr. Rajani Sharma. Could you please join us on the dais to chair the session, accompanied by Dr. Rano Singh, Dr. K. Manju, and Dr. Rupam Sinha. Our esteemed chairpersons for the next talk. Dr. Rajani Sharma, Dr. Rano Singh, Dr. K. Manju, and Dr. Rupam Sinha. May I request you to please invite our first speaker, that is Dr. Pratibha. Dr. Pratibha Singh, please. The CV has already been displayed. I think Dr. Pratibha would need more time for presentation rather than we read her whole CV.
So, just a small introduction about Dr. Pratibha. She is a senior consultant in Bhagalpur, and she holds many posts nationally. Mainly, she is chairperson IAEC FOGSI 2022-25 and chairperson Fertility and Aging Committee IMS 2023 and 24. So I will hand over the stage to Dr. Pratibha Singh. Please go ahead.
Can we start with the presentation, please? Over to you, ma'am. You need to switch on the button once.
Hello. Thank you. So thank you so much. And respected chairpersons and my dear friends, a very good morning to all of you. At the outset, I would like to thank the organizers, especially Dr. Supriya, Dr. Meena Samant, Dr. Ranjana, and all for giving me this opportunity to address such august gathering. And I also want to congratulate them for organizing such wonderful conference. Today I have been asked to talk on ovarian germ cell tumors, approach to diagnosis and management. Now, ovarian germ cell tumor is a disease in which malignant cells form in primordial germ cells of the ovary. And they are mainly composed of numbers of histologically different tumor types derived from the primitive germ cells of embryonic gonads. And in children and adolescents, more than 60% of ovarian neoplasms are of germ cell origin, and about 1/3 of them are malignant. Whereas in adult, about 95% are benign and consistent of mature cystic teratomas. 90% of they are of pure type, and about rest of them are mixed. Median age of presentation is around 19 to 21 years, and usually they are unilateral and mostly chemosensitive. So for the classification of ovarian germ cell tumor, it can be classified histologically by primitive germ cell tumor or biphasic or triphasic teratomas or monodermal teratomas. But the most frequently used classification is from WHO, which is presented in 2014, which has this following classification, that is dysgerminomas, yolk sac tumors, embryonal carcinoma, non-gestational choriocarcinoma, mature and immature teratomas, and mixed germ cell tumors. Now, many of time these young girls, doesn't have any symptoms. Usually they present with swelling in the lower abdomen without weight gain in any other part of the body, which is rapidly growing. Sometimes they will complain of subacute pelvic pain, which is mainly due to capsular distension, hemorrhage, or necrosis. Then these tumors are usually heavy, so they will present pressure symptoms on bladder or rectum, menstrual irregularities, and in advanced cases, they may cause ascites leading to abdominal distension. So initially, it is there are no symptoms, and it is hard to diagnose. But on regular gynec examination, you can find tumors, and if any adnexal mass of 2 centimeter or more in premenarchal girls, and a complex mass of 8 centimeter or more in premenopausal patient, they should be surgically explored. Now, in this, the diagnosis can also be made by tumor markers because they can give you the differentiation of different germ cell tumors. Then chest radiograph can be done to rule out any metastasis in lungs or mediastinum. Then in premenarchal girl, if these germ cell tumors are there, then karyotyping should be done because they have a propensity to arise as a dysgenetic gonads. Now, CT scan and MRI may document the presence and extent of retroperitoneal lymphadenopathy or liver metastasis. Now, how will you evaluate the pelvic mass in young female patients? By tumor markers. So all these tumor markers is done, and in a premenarchal girl, if the mass is more than 2 centimeter or less than 2 centimeter with positive tumor markers, then karyotyping should be done and surgery is required if it is positive. But in the postmenarchal girl, if the cyst is less than 8 centimeter and negative tumor markers, then hormonal suppression can be given for 2 months. And if the size decreases, then clinical follow-up done, because most of the time they can be just a hormonal disbalance. And if the size is persistent or increasing, then again surgery is required. And if the cystic mass is more than 8 centimeter, or it is solid or suspicious, and if it is there have positive tumor markers, then immediately surgery has to be performed or chemotherapy as advised. So what are the prognosis and the treatment mainly depends upon the type, size and stage of the cancer and patient's general health, along with the histopathological examination of the tumor. Now we'll start with dysgerminoma, which is the most common malignant germ cell tumor and ovarian malignancy during pregnancy. 5% occur in phenotypically females with karyotypically abnormal gonads, that is pure gonadal or mixed gonadal dysgenesis or androgen insensitivity syndrome. About 85 to 90% are confined to one ovary, whereas 10 to 15 bilateral. And if it progresses, then about 25% they can present metastasis, which can spread through lymphatics, hematogenous, or direct spread. It is highly chemo and radiosensitive and has a good prognosis if diagnosed early, and generally 5-year survival rate is more than 75%. Now endodermal sinus tumors, this is mainly derived from primitive yolk sac, and it is also referred as yolk sac carcinomas. They are malignant germ cell tumors of the ovary, and median age is around 18 years at diagnosis. And most of these tumors secrete alpha-fetoprotein, which is a marker for the extent of disease. And in histopathological examination, it shows these Schiller-Devil bodies, which are the larger vesicular nucleoli with prominent nucleoli. And serial serum alpha-fetoprotein measurements is useful in monitoring the patient's response to treatment, early detection of metastasis and recurrence. Whereas adverse prognostic factors are mainly when it grows to stage 2 or greater, or there is a gross residual tumor after cytoreduction, or when there is liver involvement. Complete cure for all stages is more than 80% of cases, although Nava et al. Found that the post-chemotherapy survival rate for the stage 1 tumor is about 95%, and only 25% survival is there when it reaches to stage 4. Now teratomas, again these are the tumors which are composed of all 3 embryonic layers, and they can be of different types. One is this mature teratoma, then another is presence of immature tissue with an embryonal appearance, which is immature teratomas, and sometimes it may be composed of single endodermal or ectodermal type of tissue, which are referred to monodermal teratomas. So mature teratomas are the most common ovarian tumors, which is of variable size and weight, occurring during reproductive age, and generally they are asymptomatic and until complications like torsion with perforation or bacterial infection occurs. The cut surface of the tumor reveals a cavity filled with fatty material and the hair surrounded by firm capsules of varying thickness. Mature solid teratomas are usually uncommon ovarian teratomas, and these tumors are generally large and solid, and they entirely of mature tissue derived from the 3 germ cell layers arranged in orderly fashions. Now this fetiform teratoma, this is the extremely rare teratoma, which is mainly resembling the malformed human fetus, and mostly it occurs in 3rd and 4th decades. And how will you differentiate from embryo? By the absence of umbilical cord and normal extremities. Immature teratomas is the second most common germ cell malignancy, which contains immature neuroepithelium, and these are tumors occurring most commonly in the first 2 decades of life and being almost unknown after menopause. The tumors are usually asymptomatic until it enlarges. It tends to grow rapidly and forms a pelvic or the lower abdominal mass, causing pressure symptoms like dull pain, and when it goes in torsion, then patient may have acute pain. Occasionally, patients have elevated serum alpha-fetoprotein or HCG levels. So in this case, the grading of teratoma, immature teratomas are very important, and it should be graded because this grading correlates with outcome and determines which patient should receive chemotherapy. O'Connor and Neris proposed that they should be divided into 2 grades. Grade 1, which is low grade, which has a slight degree of immaturity and should not be treated with combined chemotherapy, whereas grade 2 and 3, they are high grade, so they have high degree of immaturity, so should be treated with chemotherapy. Even WHO follows AFIP grading system, which is based on aggregate amount of immature neuroepithelium on one single slide. So on the slides, if the amount of immature neuroectoderm occupies less than 1 low power magnification field, then it is grade 1. When it occupies more than 1 and less than 3 millimeter low power magnification field, then it is grade 2. And when the amount of immature ectoderm occupies more than 3 low power magnification field, then it is grade 3 immature teratomas. Now, there is something growing teratoma syndrome, which is defined as continued growth of teratoma following therapy, but with normal alpha-fetoprotein levels and is exclusively benign. These tumors are resistant to chemotherapy and must be removed surgically, and if you remove it successfully, then it has a very good long-term prognosis. Stroma overi, this is again a common form of monodermal teratoma in which the thyroid tissue has overgrown all other tissues and only the thyroid tissue has developed. There is no specific clinical or radiological finding at present, and generally it is benign, rarely malignant. If malignant, then it may be papillary carcinoma, and it does not have true capsule. So invasion of capsule is not a criteria for malignancy, and even vascular invasion is quite rare. So occasionally there is extra-ovarian extension caused either by rupture of tumor or by local spread, where the peritoneal cavity will contain mature thyroid tissue deposits. This is again a very rare type of tumor, that is embryonal carcinoma, which has a common extra-ovarian spread, and in patients it ranges between the age 4 to 28 years, and it usually presents with adnexal mass, and half of the cases have endocrine manifestation with precocious pseudo-puberty, irregular bleeding, amenorrhea, and hirsutism. Serum HCG and alpha-fetoprotein levels are typically elevated, and it should be distinguished from choriocarcinoma by the absence of syncyto and cytotrophoblastic cell. And the treatment is by surgical and chemotherapy. Again, alpha-fetoprotein and HCG can be used for response of the subsequent therapy. Polyoembryonoma, again it is very rare type of tumor, usually occurring in the young premenarchal young girls, and in this it is composed of these embryoid bodies which is mimicking like early embryos. Again, it is developed from all the 3 basic somatic layers. Choriocarcinoma, again it is very rare, younger, usually present females in the younger age group of 20 years, and the presence of HCG can be useful in monitoring the patient's response to treatment. And here the patient will have adnexal mass, pain, and occasional hemoperitoneum, and presentation is similar to that of ectopic or tubal pregnancy, so that should be differentiated. Finally, the treatment is either surgery or chemotherapy, Surgery, again, these are young, so you have to see whether fertility is desired. If that is desired, then unilateral salpingo-oophorectomy or peritoneal washings or careful regional lymph nodes should be inspected, and then only should be done. Biopsy of the contralateral ovary should not be done routinely unless there is some suspicion, and because there is a risk of adhesions and ovarian failure. But fertility, if it is not desired, then complete staging and surgery can be performed. And same is the pathological diagnosis. Again, I will not go in this detail. What is the combination of chemotherapy for germ cell tumors? Just in 1 minute I'll take. And it requires this primary therapy is by preferred regime BEP, that is bleomycin, etoposide, and cisplatin. These cycles are repeated every 21 days for 3 cycles for good risk and 4 cycles for poor risk. Recurrence, if it is there, then high dose chemotherapy can be done, or it can be converted into TIP, that is paclitaxel, ifosfamide, and cisplatin. And the features of recurrence is when the tumor is growing, age is younger than 20, and microscopic feature shows numerous mitosis, anaplasias, and medullary pattern. Second look surgery, usually if the patient is in stage 1A and grade 2 and 3 and have received adjuvant chemotherapy, it is not required. But when it is growing and when there is a residual tumor, then you have to go for second look surgery, mainly to resect any residual mass. Surveillance, again, it should be done in 1 year, 2 year, 3 year, and 4 years with physical examination and all the investigations like tumor markers and X-ray and CT and MRI. This germinoid pregnancy is also quite common. Again, tumor can be removed. If it is stage 1A cancer, that can be removed during pregnancy, but if it is advanced disease, then continuation of pregnancy will depend on gestational age. And you can give chemotherapy in 2nd and 3rd trimester in the same doses as given in non-pregnant patient. Now, I'll just finish. So with this, I just want to conclude that ovarian germ cell tumor are rare, but unlike epithelial ovarian cancers, they could be early detected and diagnosed. Clinical signs and symptoms are non-specific except for abdominal distension in certain large tumors. Ultrasound are important diagnostic tool for we gynecologists, and the presence of solid mass in ultrasound examination of an adolescent or young female may raise the suspicion of ovarian malignant germ cell tumors. More information you can gather from CT and MRI. Tumor markers are also helpful in diagnosis and evaluation, whereas pathology is a cornerstone of diagnosis. Prognosis mainly depends on staging, early prediction of response to chemotherapy, and post-treatment follow-up to detect relapse. And if it is treated effectively, it carry high cure rate up to 95%. So with this, I just do appeal that we have a conference of International Academic Exchange Committee along with Ghaziabad FOGSI Society in September, on 7th and 8th of September at Ghaziabad. So I request all of you, and you all are invited for that. So this is my humble request. Please make yourself available for those 2 days. Although 6th is Tej, I think. So if those who are not doing Tej can come on 7th and 8th of September. And a lot of faculty from national and international level have already confirmed. So I again request all of you, invite you for this conference. Thank you so much.
Ma'am, you need to switch on a button वहाँ पे mic पे.
Hello. Thank you, Dr. Pratibha, for your elaborated knowledge of everything. You have told us its incidence, how to investigate in early stage, what is the clinical staging, how to diagnose so that it can be detected at an early stage and prognosis is better. So thank you very much for your elaborated this thing. Thank you.
And I would request our chairperson to please invite the next speaker. That's Dr. Amita Sinha.
Dr. Amita Sinha does not need any introduction.
Yes,
She's
thank you, madam. With these words, I can start
She's
my
consultant
presentation.
gynecologist and very close to our heart. So
Thank you, madam.
She is the secretary of our society, so everyone knows her, and she is a very friendly and jolly girl. So please go ahead, Amita.
Okay.
hard worker.
Respected chairpersons, senior members, and all my junior and senior friends. A very good morning to all of you. Now I'm going to start a talk on FOGSO. That is all you know, protection of children from sexual offenses. And FOGSO, what gynecologists should know. This is my topic. So, this is our national conference, and topic is tough for me because it is related with law, but I will try to do justice with my talk also. So I will start the presentation with a case history that you day to day find in newspaper, or sometimes your relatives or your friends or your staff come with this type of complaint. A 16-year-old girl goes to this public school by the bus, public bus, and the bus is always crowded at that time, and she rarely ever gets a place to sit. One day, while she is standing in the crowded bus, a man behind her presses himself against her. She tries to move away, but there is not much space for her to move. He then puts his hand on her breast and starts fondling it. Sarla screams at him and pushes his hands away. The man says that he has done nothing wrong and that he held her only to keep her from falling. Is it right condition? Don't you think the person should be punished? Yes, the person should be punished because the man has committed the offense of sexual assault. Second one case is same like that. A person named Arun is a 25-year-old man. He lives with his brother and is a trusted member of the family. He often plays with her 4-year-old niece, Nina, but sometimes when his sister-in-law is busy elsewhere and he is all alone with the child, he tells Nina to remove her top and dance to her on her favorite song. While she does so, Arun dances along but strokes his private parts as he does so usually. Seeing him, Nina also dances with her hands between the legs, and he tells her that this will be their own special game. And the person who can't stop as soon as possible, as soon as someone else comes near, and then he loses the game. Again, this is a case of sexual harassment. I think all of you will agree with this story and the term sexual harassment and sexual assault that I will come later on. So with this brief two cases, I would like to introduce the topic, why there is need of FOGSO Act. Because we have already so many acts for children and our underprivileged society, under 18s, under 5, but there was extreme need of FOGSO Act in the society. If we see the data of National Crime Record Bureau 2022, you all will be surprised that this is the data, how much amount has increased in last 1 to 2 years, and cases registered under FOGSO Act is more than 63,414. And apart from this, 1,62,459, showing an increase of approximately 9% cases of crime against the children. So this is very surprising data, and apart from this, whenever you will know that 98% of the FOGSO victims are girls, and 86% cases registered under the cybercrime against children were of publishing or transmitting of material depicting children in sexually explicit act. A most surprising fact is that 97% of the offenders are known to the victim. Just look at this picture, what the data says and what the state ratio. One of the parents and step parents, institution, teachers, relatives, friends, family members and strangers number are less than these our known person who are involved in sexual harassment. So the question arises, do we need to know about this fact, this act? What is FOGSO? So our learning objective of this presentation is objectives of FOGSO Act. We must know what is the objective of FOGSO Act. What are the offenses which are taken care under this act? What is the definition of particular offense like sexual assault, sexual harassment, penetrative sexual assault, pornography like this? And what are the prescribed punishment? Is it necessary to report it? Yes, of course, it is. There is need of mandatory. Reporting is mandatory, and what are the definite procedures for reporting? And if you fail to report, definitely there will be punishment. So we have guidelines for interviewing a child, and we must know the re-amendment of POXO Act, which was done in just 3-4 years back in 2019, 5 years ago, it was acted. We all know that this act was enacted in 2012, 2012 mein, and then it was amended in 2019. So these are few objectives of the POXO Act, like we have to protect children from the offenses of sexual assault, sexual harassment and pornography, and to establish special court. The term is special courts for speedy trial of such offences. Not ki chal raha hai to case pe case, date pe date, tarikh pe tarikh. Not like that. It is applicable all over the India. There was some controversy regarding Jammu Kashmir, and what this act was enacted in 2012, and it defines a child as any person below the age of 18 years, and it provides protection to all children under the age of 18 years from sexual abuse. So cut-off age is 18 years. Before POXO, we had so many acts, but these are the few acts that were before this POXO, but this is the special law, and the first time this law has been passed to address the sexual offenses against the children. And these offenses have been clearly defined for the first time in law, that offenses may be sexual assault, harassment and pornography. And it was to safeguard the interest of the child at every stage of judicial processes, for the proper development of the child in view of his or her protection for the right to privacy and confidentiality. These three things were very important. So there are many sections under the offenses of POXO Act. From section 3, it deals with penetrative sexual assault. Number 5, aggravated penetrative sexual assault, aggravated sexual assault, sexual harassment, using child for pornographic purposes, and storage of pornographic material involving child. These are 7-9 sections are very important, which are under POXO Act. You will be surprised to know why I am saying every time aggravated. So there must be some difference between normal penetrative sexual assault and aggravated sexual assault. Penetrative, again sexual assault and aggravated sexual assault. Look at this slide. Here we gynecologists must know about the definition. Penetrative sexual assault, as the name suggests, it is penetrative, and everything about intercourse, that is penetrative. I am not read line by line, but if it is penetrative sexual assault, imprisonment of the either description, that is penis or any object or any part of his body does something to penetrates into private parts of the girl or boy, this is like, or in mouth, then imprisonment will be not less than 7 years. It may extend to life imprisonment, and it shall also be liable for the fine. But amendment of the POXO Act says if the child is less than 16 years, imprisonment may go up to 20 years. It should not be less than 20 years. Fine should also be reasonable. Now coming to aggravated, because it is a very serious concern. Here, earlier I told that most of the offenders are known person. So here, aggravated words include when the penetration is committed by a person in a position of trust or authority of a child, such as a member of society, security forces, police officer, public servant, etc. For example, by any staff, principal or management staff of the hospital or any place of custody or care or protection. So this, if the category is like that, it comes under aggravated penetrative sexual assault, and definitely punishment will be more as compared to normal penetrative sexual assault. Here it should not be less than 20 years, associated with fine also, and fine reasonable includes medical expenses plus rehabilitation cost also. So these are few categories like police officer, member of armed forces, police servant, gang penetrative assault, if female child is pregnant but she is facing sexual assault, if she is suffering with HIV, life-threatening condition, if someone takes advantage of child's mental, physical disability, if she is sexually assaulted more than same person, or a child is below 12 years of age, if there is attempt to murder. These are few categories which comes under aggravated sexual assault. If the person of this category do the crime, sexual crime or sexual assault, then it comes under aggravated category. Now coming to section 7, which deals with sexual assault. Here definition is important to know, because whoever with sexual intent, here the word is sexual intent, touches the vagina, penis, anus, breast or the breast of the child, or makes the child to touch part of his or any other person, or does any act with sexual intent which involves physical contact without penetration. So it is again a big crime, and imprisonment is not less than 3 years. Aggravated sexual assault, if it is done by all those persons that I mentioned earlier. What is sexual harassment? Here it is not penetrative, not assaultive, but here if a person utters any word, makes any sound or gesture, or show any object or part of body with the intention that it shall be heard by child, it comes under sexual harassment. Pornography, you all know, if I uses a child in any form of media, whether for personal use or for distribution, it comes under pornography. If a person, according to section 15, store the pornographic material, so then fine increases up to 5,000. If it transmits or if it uses for commercial purpose, fine may go up to 7 years. This is the slide. In nutshell, I have shown that if it is penetrative sexual assault, maximum life imprisonment. Aggravated is also for life, 5 years, 7 years, and 3 years. But reporting is very mandatory in this case of POXO Act. If you know I don't report, because I have little time, I won't want to go in detail, but whenever a person knows that the concerned person has done this crime, one should immediately report the case. And this procedure should be, one should go for a special juvenile police unit to record the case, so that the juvenile police can take the action, and they should report the matter to the child welfare committee or a special court or sessions court within 24 hours of recording the complaint. If someone fails to report the case, if any person in charge of a company or institution by name knows that the person or subordinate has done this thing, he should immediately inform. If he fails, then he would be punished with imprisonment with 1 year and with fine. But a baby, a student or a candidate less than 18 years gives false complaint, it is not punishable. So these are some special guidelines for interviewing a child. आपको घर में लेना है, lady staff के सामने लेना है, उनको जहाँ बार-बार नहीं बुलाना है, police inform में नहीं रहना है. These are some guidelines. And this should be sent to special courts, and that court should be child friendly, and child protector police are cast in the role of child protector, not the abuser, as used to happen in rape case interview. So these are the procedure and powers of a special court. They can take decision, and it should be finished as early as possible. But now coming to POXO Amendment Act, that we all should know, because this act is gender neutral. लड़के लड़की दोनों के लिए है. Definition of sexual assault has been extended to incorporate administration of hormones or chemical substances to children to attain early sexual maturity for the purpose of penetrative sexual assault. This has been extended in the column of sexual assault. The act is very critical because it clearly defines child pornography. So these are the acts. The act seeks to enhance punishment for sexual offense with the provision of death penalty also. It was earlier not included death penalty. According to Amendment Act, those committing penetrative sexual assault on a child below 16 years of age would be punished with imprisonment up to 10 years, which might extend to life imprisonment as well as fine, and sometimes it goes to more than, the maximum punishment is death penalty also. But there are certain drawbacks. Consent, if child refuses to undergo medical examination, act remains silent. If the age of the 18 years becomes married, again silent. Criminalization of trauma and separation of two hospital, again this is the drawback of the act. Because if it is consensual, you can't declare it criminalized. So these are something which is disadvantages of POXO Act. POXO is always silent on consensual sexual activities. There are multiple psychological health issues. So I would like to conclude my talk there is the need of the hour to sensitize the public regarding child sexual abuse so that there is no reluctance in reporting these crimes. The investigating agencies should be well trained, and professionals like gynecologists, medical practitioners involved in the stages of investigation and trials should be efficient too, has to leave any scope of negligence on their part, and the POXO Act already makes the procedure child friendly, so we should go with this act. We all know that policy and implementation are very tortuous, but we have to navigate it. Yesterday, Dr. Jaideep Tang, FOGSI President, told because there is overlap of MTP Act, and I am fortunate to have MTP expert as our chairperson. Though, whenever any act comes, it becomes tortuous to implement. So our duty, we know that this is very tortuous, but we have to navigate it. The time will come when we would be able to do justice with all the children, and we are hopeful for the same. Thank you so much for your help.
Thank you.
Thank you, Amita, for your elaborate presentation on POXO Act. We were not aware of many of those things. And I just had one question. Suppose a small girl, a mother comes with a small girl to our clinic with a complaint of something which mysterious which has been done in her at home only. So are we supposed to report it to the police?
Yes, madam.
And if we don't, what is the punishment if we don't do it? Is it 6 months imprisonment or something?
What, madam, please repeat. Your duty is to report earliest, then?
We have to report it to the police.
Yes.
We as a clinician have to report it to the police, and if we don't do it, it will be an act of negligence. And what would be the punishment in that case?
This is if you failure of reporting, punishment is 1 year.
1 year.
One year.
That's what I wanted to know.
Yes, madam. Thank you so much.
Thank you, Amita, for your nice elaboration. There were many things that we were not aware.
Ma'am, any more questions we have, we can definitely discuss over a cup of coffee, as we have to go ahead with the next session. All right, I request our chairpersons to please join us here, and all the speakers of the previous session, please join us. We would like to felicitate you. Chairpersons, please join us. Thank you. We quickly move ahead for the next session. May I request our chairpersons, Dr. Suchita Chaudhary, Dr. Seema Singh, Dr. Rupam Chandra, Dr. Huma Nishat, to please join us on the dais to chair the session. So to give more screen time to our speaker, her CV is already displayed, and with the permission of the chair, if you can just ask the speaker for the talk. Thank you. You can long press the button. वहाँ पे.
Good morning, everybody. Thank you, organizing committee, for giving me opportunity to chair this such a wonderful session, and also introduce such a wonderful speaker, Dr. Ranjana Sinha. Dr. Ranjana is consultant, obstetrician and gynecologist, Gynae Clinic in Patna, executive member of ISO Part 2022, treasurer is the IFS Bihar chapter, former joint secretary ISO
Thank you,
Part.
madam. I think I should speak, otherwise we'll have to go fast. Respected chairpersons and dear friends, a very good morning to all of you. The topic given to me is diagnostic challenges in adolescent AUB. And as all of you sit in your OPD, you may find many case scenarios related to adolescent AUB. Like a mother of 9 years comes to you and she says that my daughter is bleeding from last 3 days. Is it normal? Isn't it early? So as all of you know, that age of menarche is coming down, and in India, it varies between 9 to 15 years. In another case, mother may come and she says that my daughter has irregular cycles. Either she bleeds twice a month or once in 2 months. So as
all of you are aware that anovulation and due to it, irregular cycles are very common due to immature hypothalamo-pituitary axis in first 2 years of post-menarche. However, as the pituitary potential to respond to GnRH stimulation and positive feedback effect of E2 progressively improve after menarche, by 5 years post-menarche, 75% of cycles are ovulatory and the cycles become regular. So just reassurance is enough. In another case, a mother may come and says that during cycles my daughter bleeds too much, and after tooth extraction also she has prolonged bleeding. So you must be knowing that bleeding disorders, bleeding diathesis, are the second most common cause and which are often diagnosed during puberty. And after menarche, if the first cycle is heavy, then you must exclude bleeding disorder in the patient. And in another case, like I got a call from a mother, my daughter is bleeding profusely, I have got a call from school. And when she came to me, she was bleeding profusely, there was products of conception in vagina, her hemoglobin was 6 grams. So always exclude pregnancy while looking at the late adolescent age group. Coming to the definition, abnormal uterine bleeding is defined as bleeding from the uterine corpus that is abnormal in duration, volume, frequency, and or regularity. And AUB accounts for half of the gynecological problems among adolescents. So what does normal menstrual cycle in adolescent girls look like? Menarchal median age is 12.43 years. Mean cycle interval 32.2 days in first gynecological years. Menstrual cycle interval typically 21 to 45 days. Menstrual flow length less than 7 days. And menstrual product use 3 to 6 pads or tampons per day. AUB FIGO recommendation for menstrual terminology in AUB is there may be disorders in regularity, frequency, amount of flow, and duration of flow. Amenorrhea, no bleeding in 90 days. Oligomenorrhea, 1 or 2 episodes in 90 days. Frequent menstrual bleeding, more than 4 episodes in 90 days. HMB, any excessive bleeding which affects quality of life. Light menstrual bleeding, less than 5 ml. Prolonged menstrual bleeding, more than 8 days on regular basis. And shortened menstrual bleeding, less than 2 days on regular basis. So, coming to the common causes of adolescent AUB, most common cause, anovulation. Second is coagulopathy. It may be pregnancy related. However, structural problems are very rare, only 1.3 to 1.7%. So if we go to Palm-Cohen classification, Cohen predominates. All the structural causes are not found mostly. The number 1 is ovulatory dysfunction, number 2 coagulopathy. So let us start evaluating the patient. The focus of initial evaluation of a patient with HMB is to determine whether the bleeding is acute and causing hemodynamic instability. Through history taking, careful history taking, physical examination, laboratory tests and radiological imaging are secondary. Basically, careful history taking and physical examination is very important. History taking, it should be done both with and without the parent being present, because sometimes the adolescents may not reveal everything regarding their sexual activity and all in presence of their parents. History should include menstrual history, sexual history, past medical history, systemic review, and family history. So what questions to be asked in menstrual history? Age of menarche. If she has early age of menarche, it will take shorter time to establish ovulatory and regular cycles. Menstrual pattern, it will help categorize the patient into etiologic categories, and events that coincided with change in menstrual pattern. Like if there is a stress, it may be hypothalamic dysfunction, if it coincides with weight loss or intensive exercise. And when did the abnormal bleeding start? Like I said, that at menarche, if the first bleeding is heavy, you must think of bleeding diathesis. Sexual or reproductive history, use, type and adherence to contraception. Many contraceptives have irregular bleeding, like if she is using progesterone only contraceptive, it may cause irregular bleeding. Copper IUDs, it increases menstrual flow. Likewise, use of condoms, history of STI, they may cause STI and thereby they may cause irregular bleeding. History of sexual abuse, forced sexual activity, recent delivery of and abortion, they may lead to infection further. Past medical history, chronic medical illness. Chronic medical illnesses may affect coagulation, like liver disease, kidney disease, and systemic lupus erythematosus, and they may also affect HPO axis, like in diabetes mellitus. Medications. Many medications may affect coagulation. Ask about aspirin and valproic acid, and also drugs that affect HPO axis, like antidepressants and antipsychotics. So all this history is important. Family history, if there is history of bleeding disorders, HMB in family, endocrine disorders, or leukemia or other cancers, they may cause increased bleeding in that patient too. Social history, like use of substance use, may indicate affecting HPO axis, and school absence may provide information about quality of life. After proper history taking, one must move to physical examination. The vital signs, tachycardia, hypotension, and orthostasis, they indicate life-threatening pregnancy complications like ectopic, bleeding disorder, severe and ovulatory uterine bleeding, or eating disorder. Fever may indicate infection like PID or endometritis. Growth parameters like short stature, Turner syndrome. If there is obesity, think of PCOS. Underweight, hypothalamic amenorrhea may be there. Examine her eyes. If there is visual field defect, pituitary tumor, lymphadenopathy, malignancy. Look at her skin and hair, acanthosis nigricans, PCOS, abnormal bleeding like bruises or pitachi, bleeding diathesis, stria, Cushing syndrome, hyperpigmentation, vitiligo, adrenal insufficiency, dry skin, excessive sweating, thin hair, thyroid dysfunction, low hairline, Turner syndrome. If there is thyroid enlargement or not, just see. And web neck and shield chest indicate to Turner syndrome, galactoria, hyperprolactinemia. If there is pelvic mass, it may be ovarian tumor. External genitalia, there may be imperforate hymen, there may be primary amenorrhea, clitoromegaly, hyperandrogenism, perineal trauma, sexual abuse, vaginal discharge, STI. Pelvic examination is usually not done, but if needed, look at the depth of vagina, uterine enlargement to rule out pregnancy, and ovarian enlargement to rule out ovarian cyst. Review of systems after taking careful history and examination. You must review all the systems. If there are bleeding symptoms like bruising, epistaxis, bleeding gums, etc., then it points to bleeding disorder. Orthostatic symptoms, hypovolemia and significant blood loss. Weight change, if there is weight loss, there is hypothalamic dysfunction. If weight gain, PCO, hypercortisolism, and hypothyroidism. If there is abdominal pain, fever, and vaginal discharge, it indicates to PID or endometritis. Dysmenorrhea, dyspareunia, infertility, endometriosis or adenomyosis, galactoria, heat or cold intolerance, fatigue, endocrine problems, changes in bowel or bladder function, extrauterine bleeding. And if there are joint disorders, then heritable collagen disorders, which have associated bleeding abnormalities due to capillary fragility. Changes in skin, hair, and nails, thyroid disorders. There are also various screening tools for assessing heavy menstrual bleeding. There are menstrual calendars. Most adolescents use mobile trackers. You may use questionnaires or PBAC chart. So what questions can you ask to help quantify blood loss? Just ask the patient, how often do you change your sanitary pad during peak flow days? How many pads do you use in a cycle? How do you need to change the pad in the night? How large are the clots? Has a medical provider told you that you are anemic? Women with a normal volume of menstrual blood loss tend to change pads or tampons at more than 3-hour intervals. Use fewer than 21 pads or tampons per cycle. They seldom need to change the pad or tampon during night. They have clots less than 1 inch in diameter, and they are usually not anemic. These are the various questionnaires and the assessment charts which you can use in your clinic and provide your patient to assess HMB. Now, depending upon the bleeding pattern, one may come at some conclusion. Like if the patient has irregular bleeding, which is unpredictable in timing and volume, think of anovulatory uterine bleeding. That is usually irregular, which is unpredictable in timing and volume. Also, PCO bleeding is irregular, which is unpredictable. Less common causes include hypothyroidism, hyperprolactinemia, hypothalamic dysfunction, and intermittent non-uterine bleeding mimicking irregular menses. All these may cause irregular bleeding, unpredictable. Coming to regular menses with excessive flow. So if the patient presents with regular menses with excessive flow, I have already told, bleeding disorder is the commonest. Associated clinical features include heavy bleeding with first period, symptoms of bleeding disorder like bruising, epistaxis, and gum bleeding, and family history of bleeding disorder. Suggested evaluations are complete blood count with platelets, evaluation of peripheral blood smear, APTT and PT, and von Willebrand panel. Less common causes of regular menses with excessive flow are medications that affect hemostasis. Just ask if she is on anticoagulant therapy. Hypothyroidism or hyperthyroidism may also cause regular menses with heavy flow. Structural regions, although rare, may be there, like endometrial polyp, congenital uterine anomaly. Now coming with regular menses with intermenstrual bleeding. So common causes are hormonal contraception if she is not taking regularly or intrauterine device, and sexually transmitted infections. Now the last one, that is extrauterine causes which is not present in inside uterus of intermittent bleeding that may mimic intermenstrual uterine bleeding. So these causes are ectropion. Just do a speculum examination to rule out. Perineal trauma, history of perineal trauma or forced sexual activity, cervical polyps, all these you can rule out by just an examination or ask for medications, that is anticoagulant therapy. So these are the uterine and extrauterine causes which may cause adolescent AUB. After coming to the conclusion, what it may be, let us move on to laboratory tests. Our aim is to determine severity of the bleeding and to investigate potential etiologies of HMB. The minimum laboratory evaluation should include HCG, complete blood count, peripheral blood smear, ferritin level, prothrombin time, activated partial thromboplastin time, and fibrinogen. These are the various disorders, bleeding disorders, and these are the battery of tests. It is available on net, you can go through it. However, one important point regarding the von Willebrand panel. The von Willebrand panel should include plasma von Willebrand factor antigen and functional test for VWF and factor VIII activity. Those with blood type O will have lower levels of VWF. So VWF antigen reference values should be appropriate for each patient's blood type. And VWF panels should be obtained either before or 7 days after ceasing exogenous estrogen treatment. Estrogen replacement therapy has been shown to increase plasma VWF level. Additional tests, exclusion of infection and evaluation of thyroid functions, and patients with a significant bleeding history and non-diagnostic initial testing should be referred to a hematologist for further investigation. Imaging is usually not recommended because the structural causes are not there, but it can be considered for patients who do not respond to initial management. And finally, the take-home messages. Anovulation is the main cause of adolescent AUB. Careful medical history is the main modality of diagnosis. Hormonal evaluation may be needed. Coagulopathy, if suspected, should be investigated properly. Detection of anemia and chronic disorders is a must, and ultrasound is rarely needed. Thank you very much. And with this, I think my next speaker, Dr. Suman Lal, my friend, is here, who will be dealing with.
Thank you, Dr. Ranjana, for such a detailed and clear-cut talk. It was very nice, very clear-cut. Congratulations.
Thank you very much, ma'am.
One question.
Yes, madam.
If all investigation is normal and if not response, then genital tuberculosis is one important cause for the puberty
madam. Yes, madam. Yes, madam. Sure.
Which tests added for genital tuberculosis in adolescent?
For genital tuberculosis, madam, usually we go for a Mantoux test and BB-NAT.
Of course.
Gene expert.
If they are
Yes,
ready,
madam.
you start.
Thank you.
Tell them. All right, so we have the next speaker here with us. Ma'am, can we display the CV, please?
No.
Hello, hello. Hello, hello.
Hello, Dr. Suman Lal. Welcome to Patna.
Good morning.
Hello.
Everyone and respected chairperson. A special thanks to organizing committee. Hello. Special thanks to organizing committee, Dr. Supriya and Dr. Ranjana, my dear friends, to give me opportunity to present here. Today we will discuss the extension of the talk which the Dr. Ranjana gave here. The diagnosis is discussed, and we will discuss now how we can manage these cases. World data says that more than 90% of girls attain menarche before the age of 14 years, but yes, they have different menstrual pattern. Therefore, any girl comes with the mother, what should be the treatment? Treatment is only reassurance, and we have to tell that she can attain the menstrual cycle by the end of 3 years of the menarche. Therefore, just keep record of the menstrual cycle, nothing to do. No treatment is required. If she has less iron store, we can add iron therapy. That's all. How common is the AUB in our OPD? Data says that 40% of the girls are having the abnormal uterine bleeding, and time to time they are coming in our OPD. Therefore, there the hormones are changing, and as a gynecologist, we should know that how we can play with the hormones. If we know that how we can play with the hormones, we can satisfy our client. If we go to the etiology, then adolescent as the most common cause is the ovulatory dysfunctions, and second most common is the coagulopathy. If we have to order one test in the endocrine disorder, just test for serum TSH, because hypothyroidism is very common in this young girl, and treating them for the hypothyroidism, mostly they have the normal menstrual cycle. For understanding the treatment plan, better we have to classify them in the 3 categories, the mild, moderate and severe. Then treatment plan will be very easy for us. In the milder cases, mostly the girls are having the normal hemoglobin. They may have the bleeding more than 7 days in the 2 successive months, but bleeding will be the mild or moderate. In the moderate, the either duration of the bleeding will be more, and they comes at the less frequent interval. They can have the heavy bleeding. Hemoglobin is less, but not more than less than 10. But if the girl is having continuous bleeding and heavy bleeding, hemoglobin is less than 10, they are the severe AUB and they require immediate attention. If a girl coming to us, she is having continuous and heavy flow, 1 pad per hour, blood clot more than 1 inch in diameter, making her hemoglobin less than 8, hematocrit less than 25, she is pale and her pulse rate is increasing, blood pressure is decreasing, it means it is an acute case of the AUB, and that required the team approach. Therefore, we should know that which patients should be admitted, which patient we can just reassure. Goal of management is always, as the patient is bleeding, we have to stabilize her first and reassurance of the family and the patient. Then, yes, control of the bleeding and treatment of anemia. And our aim is to return her normal menstrual cycle pattern, and we should give the treatment so that she will not have a recurrence and she will come in the OPD with some state. But as a gynecologist, as Dr. Ranjana told very categorically, we should not think for the uncommon cause of bleeding in this young girl, because young girls gives us lots of surprises. Now coming to the case, young girl, 12 years, attained menarche 6 months back, having the cycle every 2 months with the bleeding lasts for 7 days with the 3 pads per day, hemoglobin is 11 gram. With the clinical classification, she comes in the mild AUB. How we can treat? Only reassurance, reassurance and reassurance. She will keep the menstrual calendar, she can come to us, we will see how she is. Here the hemoglobin is less than 12. We can provide the iron supplement 60 to 120 milligram per day. The study says that single dose is better than the multiple dose. you can say that she can take 1 iron tablet in the morning, and in the evening she can take lots of iron-rich food, because receptors, whatever the iron she will eat, receptor takes the one definitive amount, not more than that. Better to give 1 tablet one time, and the next time, if you want, we can give the lots of iron in the diet. Anemia, if we want to monitor anemia, again, there's no need of going for the lots of iron study and all these, increase the load on the lab. We can just do the one test, serum ferritin, at the interval of 3 months to see the iron stored in this young girl. The second case, a girl 16 years with complaint of every 2 months amenorrhea, with the heavy bleeding 10 days, which make her weak. Hemoglobin is 10. Again, she is coming in the moderate AUB. Most of these patients can be treated as the outpatient benefit, and they respond quickly to the hormonal therapy. What hormones we should start? Most preferred therapy is the monophasic, means all the pills are having the same hormonal strength. Oral contraceptive means combined pills. 30 to 35 microgram ethinyl estradiol. This I'm saying because previously we used to give the overall G, that was the higher dose. Now we are reducing to the lower dose of estrogen with the various type of progestin. Always there's a concern that if you are giving the estrogen progesterone pills, the girls can have the less height, but most of the 90% of the height is achieved once girls is gaining the menarche. Therefore, we can give the OC pills without much fear. Yes, for the women who can't go for the estrogen pills or they are contraindicated, we can add the progestin. How we can give the OC pills? If you have decided to give the OC pills, important is to give the 3 dose, means 3 tablet a day. Then once the bleeding will reduce the dose of 2 tablet a day, and then reduce to 1 tablet a day, simple, and give it to the coverage of 21 days, starting from day 1. Then the maintenance therapy we can give to 3 months, and once the hemoglobin will be more than 12, there's no need to continue the therapy, and we evaluate the girl again. If you're deciding to give the progesterone therapy, we can give the 3 tablet a day of the progesterone, whatever we want to choose, and then we can give again the tapering dose to the 21 days, and maintenance dose can be given 10 to 12 days in a month later on. I try to simplify rather than going in the very much strength, simple dose. A 13-year-old girl attained menarche. This I managed last week only. In September 2023, had 3 cycle regular interval. LMP was in January 2024. After 6 months of amenorrhea, she started bleeding in June, and mother brought her in July 20. She was bleeding, reported an emergency with the active bleeding. She was very pale, tachycardia and breathing difficulty. Her hemoglobin was 5.6. Her beta HCG was negative. Definitely it is the case of secondary AUB, most likely anovulatory, but in this case, coagulation factors should be seen properly. Treatment of this severe AUB is always the hospitalization, assessment of blood loss, blood transfusion, hormonal therapy, and iron therapy, and investigation for coagulopathy. Adolescents tolerate the anemia better than the adult. Therefore, better not to give the blood transfusion if hemoglobin is more than 7. If hemoglobin is less than 7, you have started the blood transfusion, give the order of 1 transfusion at a time, then re-evaluate the patient and see the hemoglobin status and status of the other hemodynamically stability, then advise for the second transfusion. Not as a blanket, C is 5.6, give the 2 transfusion, we should not. If you have decided to give blood transfusion, order for the packed RBC. Hormonal therapy generally is the same as we started in the moderate AUB. The monophasic OC pills, we can add even the 4 tablet a day, and once it diminished, and we can taper the dose, give up to the 21 days. If the bleeding doesn't decrease after the 2 doses of OC pills or an average up to 24 hours, better to start IV estrogen till the bleeding will be controlled, and then we can switch over to the oral estrogen. If the bleeding will not stop in the 24 to 48 hours, even started the conjugated estrogen, consultation with the hematologist should be considered seriously. Once the hormonal therapy has stopped the bleeding in this adolescent, maintenance therapy is required for 3 to 6 months, and in some cases longer also if there is a bleeding diathesis. Estrogen usually causes lots of nausea and vomiting, and therefore the girls stop the medicine in between. Better to provide the antiemetic with them. An iron supplement is always needed to restore their iron store. Generally, we give the tranexamic acid in our OPD very much, and yes, it can decrease the menstrual blood flow in the young female as the OC pills does. Dose we have to give, the maximum dose at one time is 600 milligram. The one concern, if the OC pills is already thrombogenic and if we are adding the tranexamic acid, there's always the theoretical risk it can increase the thrombosis. But long-term trial has failed to demonstrate that. Therefore, in selected cases with the proper explanations to the parents and family, we can start the 2 drugs together, but with the caution. Again, the 14 years girl, she started heavy bleeding for more than 10 days at the onset of menarche. Hemoglobin is 6, mother is having history of heavy bleeding during childbirth, brother has some coagulation abnormalities. Yes, resuscitation and correction of anemia is there, hormonal therapy is needed, but yes, this patient raised the alarm, she is having coagulative disorder, and team approach is needed in this case. Again, I discussed this, always a gynecologist should know how to play with the hormones. And hormones, estrogen is the same, only the progesterone which can add the changes, and that makes you the better gynecologist than the other. Being a corporate, I can say that. If we see that there are 4 generations of progesterone, and the first generation is norethistron. Generally, we give the Pribulut-An and other medicine. And first generation is the pure progesterone, is the medroxyprogesterone acetate. Even the cyproterone acetate with the diene and all these 35 things comes at the first generation, but it has the ideally it is anti-androgen, having the progesterone-like activity. Second generation progesterone, generally the overall L and all these, we have the levonorgestrel. Third generation is in the novolon, femilon we are having. Fourth generation is drospirenone and dinogest. Important to understand that as the generation increases, breakthrough bleeding decreases. And as the generation increases, potency is also increases. And 2 progesterone, first generations and fourth generations are anti-androgenic. They give help to the women who are having the lots of anti-androgenic actions like the acne, like the hair growth over the face. 4th generation progesterone like the drospirenone have the anti-mineralocorticoid property, where the water retention is much more, they really help the girl. But at the same time, we should not forget they increase the thromboembolic episode. Considering all these things, progesterone, we can have young girl having the 18 years delayed period with the heavy bleeding, weight gain, acne, and water retention. Generally, we have to choose the 4th generation progesterone. Young girl with the history of thrombotic event in the family, we should not choose the 4th generation progesterone, we should go for the 2nd generation progesterone. A girl on the OC pills having the irregular cycle off and on, most common cause is the missed pill, or you can change the OC pills with the 4th generation progesterone so that breakthrough bleeding will decrease. Again, I told कि the girls gives the lots of surprises. 17-year-old girl visited in emergency with a bleeding PV for the last 2 days, lower abdominal pain. She had the period 1.5 months back, thought of menstruations. Examination is very important in any of the case. As a clinician, we examined, there was right iliac fossa tenderness. We did ultrasound and there was hemoperitoneum and echogenic mass. Her beta HCG was 200. She was ectopic pregnancy. We did milking, milking of the tube. And the second girl is also having the mass inside the uterus, and histopathology showed the retained product of pregnancy. One young girl visited with a mild to moderate bleeding for 2 days, having amenorrhea for 3 months, and the LMP was 10 days ago. She was taking the progesterone pill and tranexamic acid, but surprisingly, she had bikini wax 2 days back. There was large labial tear. Therefore, as a gynecologist, we should think all these things. Surgical management, generally, we should keep aside, and very rarely we should go for the surgical management. And recap again, the menstrual bleeding, we should think for the bleeding disorders, and monophasic contraceptive is the mainstay hormonal therapy. NSAID we should give with the precautions, because if the woman is having bleeding disorder because of the platelet defect, we should not provide them the NSAID. Thank you.
Thank you, ma'am. Thank you so much. I request all the speakers of our session to join us. Ma'am, you need to long press the mic button.
It was a very elaborate topic and very nicely dealt with. Thank you so much.
Is there any role of desmopressin? Is there any role of desmopressin in...
Ma'am, for the questions, we can just take it over a cup of coffee, because we are much beyond time. And I request all you chairpersons also to... We would like to felicitate our chairpersons as well. Please join us. Quickly move ahead for the next session, which is going to be a panel discussion. I would invite our moderators, Dr. Charulata Bajpai, Dr. Meena Savant. Moderators, please join us on the dais. Dr. Charulata Bajpai and Dr. Meena Samant. I would like to invite our experts, Dr. Rita Jha and Dr. Zarina Rahman. They are going to be the experts, Dr. Zarina Rahman. With your permission, can I invite?
Yes, please. Yes, please.
Thank you. The panelists, Dr. Archana Jha, Dr. Suniti Sinha, Dr. Mamata Singh, Dr. Tabassum Ahmed, Dr. Vinita, Dr. Divya Suman, Dr. Anjali, Dr. Ritu Singh, and Dr. Nisha. All our panelists, please join us on the dais. 3 chairs are behind you. Those chairs are there. So we, madam, यहीं पे रखिए.
Why is the next slide not being seen? So good morning everybody. Thank you very much for this opportunity, and I wish to thank Dr. Supriya Jaiswal and Dr. Meena Samant for this fantastic opportunity. We have some esteemed experts and fantastic panelists for this beautiful discussion on navigating breast problems in adolescents. I'm really grateful to Dr. Meena for being here with me as my co-moderator. The breast is indeed an organ of growing concern. The form, function and pathology of the female breast are major concerns of medicine and society. As mammals, the breast nourishes the young. The breast contours occupy our attention. Asymmetry, congenital defects are going to worry the adolescent significantly. It affects their psychology. As obstetricians, we enhance or diminish its functions. And as gynecologists, the appearance of inappropriate lumps and discharge is going to worry us a lot. And this could signify serious disease. So welcome esteemed panelists and experts, and we are going to have a great discussion. We would request you to give brief and significant answers because of shortage of time. Over to you, Dr. Meena, for the first case. Okay, take it. So I think let us just, Dr. Jha, could you just, we know about the Tanner staging. So why do we need to know about the Tanner staging?
Actually, I must thank for giving me this opportunity. Actually, Tanner's staging is related with the development of breast.
Yes.
So it is very important to know each and every gynecologist that what the stage is.
Yes.
If it occurs, the breast development occurs before 6 years, then it is precautious, and if it does not occur up until 13 years, then it is.
Yes, fantastic, very important take-home message that if it occurs before 6 years, it is premature development. If it is beyond 13 years, it is delayed development, is what we need to remember. And so now, I think Madam Meena will take over.
Yeah, we've written the names from whom we need the answers, but if they're not there or anybody wants to add, they are most welcome. So the first case is a very not maybe so much common. 18 years old youngster, she's complaining of throbbing pain around the right breast nipple. She is obese. On asking, she gives history of nipple piercing. 10 days back, we can see such cases more because they're becoming more kind of fashionable, all kinds of fashions coming up. Now, on examination, redness, periareolar swelling, tenderness on the right breast, left nipple piercing site, minimal inflammation on the site of where it is there. On the left side, there is minimal inflammation. How should you proceed?
Hello. So this is a case of breast piercing. So first is the history. After proper history, when it was done and where it was done is most important, because sometimes it is done by the local people where the hygiene is not maintained. So proper examination of the part, whether there is any sign of infection or any abscess is there, the management depends upon that. So if there is signs of infection, proper antibiotics and hot compresses is advised, and if needed, ultrasound guided aspiration of the abscess should be done. Sometimes the most common bacterial infection is staphylococcal, enterococcus, streptococcus infections are there. So antibiotics should be prescribed according to that. Cephalosporin groups or that is erythromycin group is prescribed usually. If needed, drainage of the abscess can be done. Thank you.
Well, thank you, ma'am. I think, does anybody want to add something to it?
Because at our place, it is not very common. We have seen piercing of ear lobule of so many places in the umbilicus. I have seen, but not seen of that nipple piercing. So it is not so common at our place. But she has answered very well, and I think it is enough.
Maybe, madam, because they have not got infected, they will not show you
but
the nipple.
one of the most important morbidity is infection only, and that should be taken care of, because this is very common with nipple piercing, and she should support her breast with a soft bra and all.
And also sometimes
the basic
material.
principle is that it should be managed like a case of mastitis or breast abscess.
Perfectly
That's
correct.
all.
Perfectly. So Dr. Mamta, are there any other causes of abnormal nipple discharge in the adolescent?
Yes, though it is rare, but it is seen in many conditions. First, we have to estimate what appearance of the discharge, whether it is serous, or it is serosanguinous, or it is milky, or it is bloody, or whether it is coming from one breast or from the both breasts, or is it coming spontaneous, or it is express discharge. According to that, we should go for the different investigations like serum TSH, prolactin,
Right.
ultrasonography, and we may need MR mammogram also, or to reach the diagnosis accordingly, the diagnosis is reached and we
Yes.
plan for the treatment.
So we
for
just
the
have to
discharge.
remember
like,
that
some conditions like mammary duct ectasia or
Yes.
intraductal papilloma, they should be treated according to the for like breast cancer like conditions. So we have to differentiate those conditions from breast cancer and go for microdocectomy in that condition.
Yeah, well said. We have to remember that although cancers are rare in adolescents, we cannot rule out malignancy because nowadays in India we are seeing breast cancers at a very young age. So any young girl also with any abnormal nipple discharge has to be treated with a lot of caution. Thank you for that input, doctor. Thank you. So Dr. Tabassum, over to you. You have this 22-year-old sexually active unmarried girl. She comes with a complaint of a lump in the right breast. Now she has had it since 10th class, that means she was 15, 16 years of age, but now it is somewhat bigger and occasionally painful. You ask her about family history, there is no family history of breast cancer. You examine and you find a 2.5 to 3 centimeter mobile solitary non-tender lump in the right breast. So after examination, what would be your diagnosis? How do you counsel that young girl and what do you do ahead?
So as in this case, I am seeing that the girl is 22 years old. 22 years old and she is unmarried and she is having a breast lump when she was in class 10th. That is round about the age of 16 years or so. And now she is 22 years. So
Yes,
she is
madam.
having,
What is the diagnosis and management?
Yeah, I'm just coming on to the, so according to the history, what the history you have given, that the lump size is about 2.5 to 3 centimeter, it is mobile, solitary, non-tender, and the lump is about of the same size for the past 6 years. So it comes to that the lump is probably of a benign nature.
Yes.
And for the confirmatory, so my provisional diagnosis comes that the lump is of benign nature.
Okay.
And now I have to follow the triple assessment algorithm.
Fantastic.
And according to
So
that,
can somebody just highlight what is the triple assessment algorithm? Yes, doctor.
So triple assessment basically has 3 arms. The first is the examination, which is clinical breast examination,
Yes.
which is then followed by imaging, which would be either mammography, ultrasound or MRI depending upon the risk of the patient. And thirdly, we go in for some histopathological examination, either cytology or biopsy, depending upon our previous findings.
Picture perfect. I think the triple assessment algorithm has revolutionized the management of any breast lump. It is very necessary to go in this particular order in a compulsory manner. Please don't do biopsy before imaging. And as far as youngsters are concerned, we always prefer ultrasound as the first line. Yes, madam. Now you have done her ultrasound, and what do you? I mean, you just see a lump. So the features are, it is more transverse than vertical.
Yeah.
So what would you be your
in
diagnosis?
case of fibroadenoma,
Yes.
the hypoechoic lesion which we see with a high frequency transducer,
Yes.
it is more transverse than the longitudinal length.
Yes.
So it goes in favor of a fibroadenoma and it has got a well-defined margin, it is hypoechoic, and all these are favoring by the ultrasound
Yes.
that it is a fibroadenoma.
So can we ask our experts as to would there be any case where you would not want to do any investigation, or you think that every breast lump needs to be investigated?
If she's a young girl and the size is small and it is not giving her any symptoms, we can just follow her up.
Yeah, but we will always investigate.
Yeah.
We will always investigate. Yeah?
Even
So-
if it is a small lump, but we should evaluate and regular follow-up is
Absolutely.
essential.
So can somebody take up the question of, now this girl is just 22 years old, we have diagnosed it to be fibroadenoma, how will you manage her? Anybody?
Yeah, I'll explain to her that on ultrasound examination it has come to be a fibroadenoma and
Yes.
it is mostly they are of benign nature, but to come to a confirmatory diagnosis I have to get a FNAC or a biopsy done of the mass.
Yeah, so we can have a great debate on whether every lump needs to be biopsied or not, but if you ask most breast surgeons, they will say yes, please biopsy every lump, but sometimes if ultrasound features and clinical features are good, then yes, that is right, madam. But would you advise her surgery? or we want conservative management? Yes, madam, you can take up the question.
Ma'am, this size of lump actually doesn't need surgery.
Okay.
Only the follow-up is needed and
Okay.
the proper counseling of patient should be done.
Yes,
only.
yes.
Because risk of cancer developing at this particular age or this small tumor, which is most likely fibroadenoma, is very, very rare.
Absolutely rightly said. So the only indications for surgery would be if the patient, in this particular case, if the patient demands it, or if any finding you feel that there is some high risk for breast cancer, if there's a very strong family history, or if it's a very large giant fibroadenoma. Yes, madam, you could take. Yes.
More than 5 centimeter in size, and it is of complex nature. And if it is this lump is small, but if it is more than 5 centimeter in size and it is complex in pathology, then
yes,
it will be.
Yes. So has anybody tried ormeloxifene for multiple small fibroadenomas?
We have tried it.
Have you had good results?
I have tried it, one tablet weekly for 3 months, and there is reduction in size.
Definitely.
And pain also
especially when they are
decrease,
multiple and tiny, you can do nothing actually. So medications can help. So thank you so much for that great discussion, because fibroadenoma is a very common condition. If it is a small and proven benign one, I'm sure we gynecologists could do the removal ourselves also. Over to you, Meena, madam, for the next case.
So here one mother, 45 years old, she comes with a 18 years old daughter. Now this lady has suffered from cancer breast at the age of 42, and her aunt also had CA breast at the age of 50. So she wishes to know how her daughter should take care of herself. How will you guide her, Dr. Divya?
Thank you, ma'am. First of all, reassurance is important. We will make the lady and the girl breast aware. We will ask her for aware her about self-breast examination, and we will make her know the different conditions regarding breast, and when she should, if there is anything important, when she should come to doctor. And we should...
she knows how to, that she should do. That is why she has come to you. What specifically will you tell her regarding her own self-care?
Self-breast examination is very important. Yes. We will ask her to do self-breast examination just after her menses, and bilateral examination is important, and we will teach her the steps of self-breast examination, how it should be done, and bilateral
I think not many people know exactly how to do. Can you, for their information, tell to the audience how you will tell exactly what anybody can take?
Okay, so first and foremost, they have to understand that if they are menstruating, it should be done after the cycles are finished, because we usually have some tenderness and heaviness in the breast just before or during the cycle. Then they have to stand in front of the mirror. They have to bare themselves up to the waist, look at themselves in the mirror, see their breast so that they are familiar with their own body, so that they can understand if there is any change in the look of their breast itself. That's first and foremost. Secondly, now they have to palpate their own breast. Usually you do it with the opposite hand. So if you have to examine your right breast, you'll go with your left hand, and the other vice versa. So we palpate with the palm, with the part of, not the fingertips, but rather the fingers and the middle portion of your finger, and goes in a circular manner. Divide your breast into 4 quadrants. Deal with each quadrant. Go one by one. Do all the 4 quadrants. Palpate behind the nipple as well to see if there is any mass that the person can feel behind the nipples. Very important is to palpate the axilla as well.
Fantastic. So you tell her that is a self-examination.
Also we should add to express any nipple discharge is there or not.
Definitely,
That
that's what I forgot. Okay.
So here, this young girl, she has a family history of breast cancer at a younger age. So now we do know that she has a tendency, and we know that we have some genes responsible. So what do we do about this? In this age and era, when you have such a high-risk family history, you just can't get away with self-examination only once a month.
When there's a history, in the family history of breast cancer, so in this condition we can ask the patient, a proper history is there, and we should go for genetic testing, MR mammogram, that should be advised in the high-risk patients, and that genetic testing for BRCA1 and BRCA2 genes should be done, and mammogram should be done
In whom?
beyond.
In whom?
Huh?
BRCA1 and 2 in
Those
whom?
high-risk patients with first-degree relative having breast cancer or colon cancer, or ovarian cancer or prostatic cancer in the first-degree relative is present, then they are high-risk patient, and those MR mammogram or BRCA gene mutation, testing should be done, and mammography should be done from the age of 25 according to NCCN guidelines, and from the age of 30 according to the American Cancer Society. It should be done annually, and to reach the early diagnosis. And also some surgeries planned, prophylactic mastectomy or prophylactic salpingo-oophorectomies are advised in these high-risk patients. And it is to be done if the family is completed or beyond up to 35 years of age group. And routine TBS and CA125 levels are also done in these cases to rule out the chances of ovarian malignancy or breast malignancy.
Absolutely. So for this young girl, you will always make sure that she undergoes regular screening. She is high risk, so she has to have what is called as, for high risk young girls also, mammography plus MRI annually starting from the age of 30 is what is indicated. And for 20 and above, nowadays we talk about self-breast examination and clinical breast examination. This is extremely important. For youngsters, ultrasound is usually the first line, imaging modality, but mammography and or MRI will be added depending upon the risk factors. So we just talked about the screening of the high-risk adolescents, and we can move ahead to Dr. Suniti, because I'm sure we get these young girls, 22-year-old girl comes into your clinic. She's embarrassed, shy and slouching all the while. She soon discloses that she's ashamed of her 38C size breasts and has started developing backache because of that. She wants to know if you can help her in any way.
Generally, we come across this type of cases in our private practice and also in practice. They are ashamed of this large breast. So usually they come to us. If there is nothing abnormal, no abnormal finding on proper examination, only thing we can do is the reassurance that it's normal. And it's always, sometimes it's genetic also. So only reassurance, and if there is any problem because of that, like backache type of thing, then symptomatic treatment should be done. Otherwise,
right. Now, do our experts want to add on this? Can we do anything for this young girl? Esteemed experts?
We can tell her to reduce weight.
Very nice.
And that can reduce size of the breast also.
Yes, very
and
right.
support breast supports, that will relieve pain as well.
Yes, yes, indeed. A good breast support, weight loss, and of course, again, as we are discussing about the modern era, girls are aware of cosmetic surgery. So, would we want to offer her cosmetic? Suppose she's 16 years of age. Do we advise cosmetic surgery? No. There is a minimum age, at least she has to be 18 and above before we offer her cosmetic surgery. So, this is important to remember. Now, Dr. Mamta, there is another young girl who comes to you. She has a number of questions. She has small breasts and she is very upset about that. So, can she eat something to increase the size?
A healthy diet.
Okay. She has seen a lot of ads on internet advertising creams. Can they help?
No, no, no.
Not really. Does small breast mean low fertility potential?
No, no.
Not at all. And does it mean she will not be able to breastfeed?
No.
Very good. Can she take some hormones to make them bigger?
No.
Not necessary. Okay, great. So these are very important questions which we all face. Of course, we have to rule out a number of syndromes which can be responsible for small breasts. But she's at the age where she's so conscious. She wants to wear beautiful clothes. She says, my breasts don't show well. So how will you help her?
First, it's very important to build the self-confidence.
Wonderful.
And increase the self-esteem in
Fantastic.
that girl.
Fantastic.
And we can advise surgical and non-surgical, both advices.
Yes.
Non-surgical, we can advise she should wear padded bra or
Fantastic.
well-filled bra, or surgical technique here, that is augmentation mammoplasty.
Absolutely.
In which we place the silicone implants
yes.
Below or above the pectoralis major muscle, and this is done
That's right. So if it is affecting her tremendously, this is all available today, and we should let her know that it is available. So moving on to our last case, 23-year-old got by her parents with complaints of lump in the left breast since 1 month. Grandmother had CA ovary, father has a lymphoma. They are very worried. Dr. Vinita, how will we proceed? I think who wants to take this question? Anybody can take.
Ma'am, actually there is a history of lymphoma and carcinoma in her grandmother. Besides, she is having only 23 years old with breast lump. The genetic testing should be done in this case.
पहले उनको तो lump already आ गया है. So
Yes,
first, now we have to investigate the lump.
Okay, ma'am, we will go for again the diagnosis according to the triple assessment.
Yes.
We would go for ultrasound,
So can
MRI,
we just,
tissue diagnosis.
for the benefit of everybody, enumerate the signs of breast cancer?
Breast cancer, there will be lump which is hard, irregular, fixity will be there. There could be bloody nipple discharge with skin retraction and all. These, if there is any sign of these kind of things, the features are more suggestive of carcinoma.
Right. So you find a small lump, it doesn't, you cannot really make out too much. Which will be the first investigation that you will do for this patient?
If there is lump, ma'am, we should go for always a biopsy, tissue biopsy.
And we want to stress upon, can our esteemed experts tell which biopsy is recommended for any breast lump today? Last question.
Excisional.
Yes, it is only and only core needle biopsy, friends. And that too, if it's a small lump, it has to be an ultrasound guided or a mammography guided biopsy, and always only a core needle. FNAC, I agree, maybe we all need to learn core needle biopsy. We are having a workshop in Pune, 10th and 11th of August, where we are going to teach our gynecologists about core needle biopsy. But gone are the days where we talk about FNAC. Very negative reports are very high, and we miss many cancers. Gynecologists are usually the first line of contact, and we need to know about core needle biopsy. So we did a tissue diagnosis. Now because she's 23, she was going to get married in say 1 year or so. Can we just add one word about fertility preservation? She's got CA breast. We diagnosed that she has CA breast, and she's going to need chemotherapy, surgery and everything. So as a gynecologist, it's our duty to talk about fertility preservation. So I think we all are very aware that today oocyte preservation is very common, and we can definitely offer her oocyte preservation. She should at least know about the presence of oocyte preservation, because later on if radiation and chemo destroy her ovaries, then we will be blaming ourselves for this, and we need to know so many things about malignancy. So kindly offer your patients. Okay, our last case, Dr. Ritu. Bilateral breast pain, again a very, very common problem in most adolescents. How do we handle breast pain?
Thank you, ma'am, for the question. For the bilateral breast pain, first of all, we will ask to the patient if it is localized or generalized. Then we will ask if it is related to menses, it's occurring premenstrually or not. Then we will ask if its association with caffeine intake, smoking, alcohol, there is history of trauma is present or not. Then in family history, we will ask if there is history of CA breast in the family, or ovarian cancer is there or not in first degree relative. And then also we can grade it according to pain scale.
So we have cyclicity, or it is constant, history, whatever you've said is all very relevant. And if it is non-cyclical, injury, infection, all that we have to keep in mind. And sometimes it may not be a mammary pain, it may be extra mammary also that we have to take into account. And breast cancer, which is non-cyclical, very rare in this condition, but we always must have that. We know that from cancer cervix, breast cancer has gone to #1 and the age is decreasing. So I think we've talked about maybe the reg signs also we have talked, and he's just giving me killer looks. So I think, Madam, you can just conclude by this.
Just take one take-home message from all our panelists and experts quickly. in 10 seconds about breast health in adolescents. One take-home message from all.
As breast cancer is increasing, so we have to make aware about the breast changes and the early signs of carcinoma and breast cancer, and clinical exam, self breast examination after periods, clinical examination, and when needed, mammography and sonography.
Thank you.
Don't be ashamed of your breast examination. Do breast examination daily. And daily, not much, in 1 month you have to do it.
If you find any lump which is painless or it is painful, either way it is, you should consult your doctor immediately and follow the advice of the doctor and do self breast examination. If at all you have got a family history, then start self breast examination earlier, before the age of 20.
In this changing era where breast development is a mean of it somehow affects the confidence of adolescent, it's very important to be breast aware. Don't blindly follow the ads, commercials. Please visit your doctor, please.
And all the schools, in the schools programs should be there for the breast examination of the girls.
Yes, that is picture perfect.
Ma'am, I would request every adolescent and woman to be aware of their own breast. Actually, they should know about how is the changes going in their breast. And India literacy is very poor, so I will also counsel about the screening program, when to start, when to do and all. Yes.
Be less about cosmetics, more about pathology. So be aware of family history, their risks, and go accordingly.
Actually, alertness and awareness, these two things are very important, and we should not neglect any lump, anything in the breast, any pain. And this is the message, alertness and awareness, because it is number one nowadays.
As a primary care physician for any adolescent girl or a lady, we should know triple assessment protocol, and we should follow if there is any pathology related to breast.
I also just want to add one thing, just don't follow the Google blindly. I just had a young girl brought by her mother, and her breast was sagging like an old woman. She said, I don't know what she keeps ordering from the Google, from Amazon, and she keeps drinking this tea, that tea, and now look what has happened. And now the girl was now forcing her, troubling her mother, ki I want some surgery for my breasts. So, I mean, it can be really very dangerous if one is experimenting with whatever they are selling on that.
And we as gynecologists are the first point of contact for most adolescents and women. So we must be very aware of all the breast problems, and we should take the breast back as an organ from the surgeon. Thank you so much for this opportunity. Thank you.
All right, so I'd like to invite all the panelists, experts and moderators to please come forward for a picture. And we have the mementos also been given by Dr. Pratima Kumari and all. Please come forward. Quickly we go to the next panel discussion. I would like to invite the moderators, Dr. T. Ramni Devi and Dr. Mukta Agarwal. Dr. Mukta Agarwal and Dr. Ramni Devi. All right, so with the permission of the moderators, I'll invite your panelists on the dais. May I request our experts, Dr. Neelam and Dr. Anjana Sinha, to please join on the dais. Our experts, Dr. Neelam and Dr. Anjana Sinha. Our panelists for this session, Dr. Vinita Sinha, Dr. Ruma Goswami, Dr. Dipali Prasad, Dr. Shraddha, Dr. Prachi Singh, Dr. Anuja Singh, Dr. Shikha Sahai, Dr. Anita Paswan, and Dr. Rajani Priyanka. All the panelists, can we have you on the dais, please? The sooner you come, more time we have. Please join us quick. कोशिश यही
Only we have 4 finalists.
क्योंकि presentation के लिए आप कितना मेहनत करते हो.
Okay.
I know.
That's enough.
Do we have our experts here? Do we have Dr. Neelam and Dr. Anjana Sinha present? I'll do that.
We'll start by then.
By the time you can start.
Good morning, everyone.
Dr. Simmi Kumari.
It is my proud pleasure to be with Patna Society for this adolescent conference. And I welcome all my panelists along with my co-moderator for this very important topic of adolescent endometriosis. So the adolescent endometriosis is a disease that is, it's not getting projected. Slide projection. Okay. It is often unrecognized, ignored, mislabeled in the adolescent population. Frequently that results in 2 major things, that is a chronic pelvic pain and adhesive disease, and later on it leads to infertility. Atypical presentation in adolescent girls are very common, but the thing is, if you start treating the patient, will the patient have a quick relief, and whether she can be prevented from having a severe disease, that we do not know, because each patient behaves differently. Even it is a progressive disease that we have to understand. So I think that's an apt topic for this conference. And most important thing is 5 to 7% of the individuals, the teenagers, they have incidence of endometriosis, and 25 to 50% of the girls with endometriosis, they have dysmenorrhea. See, if a teenager presents with features of progressive dysmenorrhea, take it for granted that she is probably suffering from endometriosis, and start doing her even though the investigations are negative. That too, if she has a family history, then the chances are high. Again, NICE guidelines in 2023 has clearly said that we can boldly start the patient on treatment if she has only dysmenorrhea. So, then again 50 to 70% of the teenagers who are undergoing laparoscopy, they are found to have endometriosis. The incidence is still higher if it is being done by a senior endoscopist. And most of them, 2/3 of them are likely to have early endometriosis. But don't forget that 33% of these patients, they have severe endometriosis, that is deep infiltrative endometriosis is not uncommon in adolescent girls. Nowadays we see huge masses of endometriomas and even adenomyosis in young girls. So this is case 1.
Thank you, ma'am. And we would like to welcome 2 of our experts, Dr. Neelam madam and Dr. Anjana Sinha madam. So before starting the panel, I would just like to highlight that we are discussing the very common clinical cases, and I would like to request our panelists that we should be practically oriented, and this should be some take-home messages if we can modify few of our practices after this panel. So here is our case 1, which is a very common presentation in our day-to-day OPD. She is a 14-year-old girl who came to us with dysmenorrhea and even intermenstrual cycle pain. She has a history of premenstrual spotting as well, and during these days she refuses to go to school, and she does not participate in any of the social activities like dancing or exercise. And this dysmenorrhea is progressive in nature, and she attained her menarche at the age of 11 years. Since then, her pain during cycle is ever increasing. So, what is your diagnosis? We can start. Any one of you can start, and we can just take the discussion. Yes, Dr. Anuja, long press. Someone from the AD team, if can help with the mic. Long. Mic दे दें.
Talk without the mic. Go ahead. Yes, yes.
Pull the mic very
First of all, as we said, this history is important, in which he is already complaining of spotting and progressive dysmenorrhea. The first thing that comes in mind is we should go for a simple ultrasound. Transvaginal ultrasound is not possible, so we'll go for a normal ultrasound and go for the diagnosis. If in ultrasound we don't find any other abnormalities, then we can give, think of normal cyclical pain or mid-cell pain, and some patients may be more sensitive to it also. And accordingly, we can treat her normally like NSAIDs and everything, and thereafter.
First of all, we need to, by the history only, we need to differentiate if it is physiological or pathological. Because it's very common of having primary dysmenorrhea or the ovulation Mitchell-Mertz syndrome. But
So that is why I said that it may be a normal Mitchell-Mertz pain, but since it is progressive in nature, we can go for an ultrasound. If in ultrasound we are not finding anything.
See, just from the history, I am asking you a simple question. Do you think it is physiological or pathological? If it is pathological, you tell me what are the positive findings.
Ma'am, since her dysmenorrhea is increasing, she is being absent from school and it's progressive in nature. Her lifestyle is getting worse day by day. So there is a high degree of suspicion.
So these are the 3 points.
It goes in favor of
endometriosis. So apart from that, the patient is likely to have a premenstrual spotting. School absenteeism. School absenteeism when it is beyond a certain number of days. For example, if it is going to be more than 18 days per annum, or if she refrains from her work when she is working, then we can 100% label that she is a case of endometriosis. Yes.
This dysmenorrhea is affecting her quality of life, so endometriosis should be kept in our differential diagnosis.
So how will we proceed with this patient after this history taking? What all
we take with the history, then come to the clinical examination. From the history, we have to also look for the family history, any medical history of any taking drug that relieved her pain during menstrual period, or any contraceptive history or any other drugs that she is taking to relieve her pain. And then come to the physical or clinical examination of the patient, the per-abdominal examination, look for any other ovarian tumor or any adnexal masses, then per-rectal, if it is not sexually active, then ultrasound examination, per-abdominal trans-abdominal examination and per-rectal, that is transrectal ultrasound. If it is not very conclusive, then we go for even the MRI.
So, as we discussed in the history, we should exclude after pain symptoms any bowel or bladder symptom in the form of dyschezia, hematochezia, anything, any psychological help if this patient is needing, the sexual history, contraceptive history, family history as told by the panelist, and the symptoms as affecting her daily activities.
So when she is taking contraception for control of dysmenorrhea, that is more significant. So what are all the symptoms of endometriosis associated pelvic pain?
Okay, the symptoms can be pain, it can be cyclical, acyclical. There can be few presentation with the irregular menstrual bleeding, with the bladder and bowel changes will be there, with some amount of vaginal discharge can be present in the patient too.
See, I put it this way, 7 Ds. Dysmenorrhea, dyspareunia, dysuria, dysphagia, diffuse abdominal pain, difficulty in conception, depression, and fatigability at the end. So this is 7 Ds. Out of the 7 Ds, even if you find 2 Ds are positive, take it as endometriosis and treat them. So this you can slip. So what is the impact of delay in diagnosis?
So if a girl is suffering from pain, that is if she has endometriosis, it affects her quality of life, which has an implication that if she's a student, she's absent from the school. If she is working,
So that way also she had to take leave from the office. So those are the implications. Apart from that, it affects the fertility also. And it has
It led to delayed diagnosis, lead to progression of the disease. I think it lead to increased progression of the disease, and if delays diagnosis, it affect the future fertility also.
Yes. See, one thing is, if you are going to do the patient has symptoms, but she doesn't have ultrasound diagnosis when she is in stage 1 or stage 2 endometriosis. Is there any other modality to diagnose endometriosis at that stage?
Per rectal examination, ma'am. Per rectal.
No, I am not telling about the clinical examination. Let me.
MRI.
MRI, microRNAs are now coming up in a big way. And though the guidelines says that it can be used in the purview of only research setting, but there are already people in the European countries where they have started using kids by salivary, doing a salivary miRNA. And I have worked extensively on this, and we have published our thing for more than 300 patients, where we find out that some of these miRNAs are dysregulated and they are very specific for endometriosis. So miRNA can only pick up the lesions which are beyond 1 centimeter only. Okay, then. But the major advantage of doing miRNA in a woman who has got an adnexal mass, what is the advantage? Because we have to differentiate endometrioma from?
We can also differentiate other types of ovarian tumors, teratomas or dermoids.
And the common tumor is dermoids.
Yes, sir.
Okay,
so
but the clinical, what is the clinical differentiating point between a dermoid and an endometrioma?
Mostly the
Fluid
on
Clinically, the examination and then with the imaging.
dysmenorrhea, chronic pelvic pain is
Suppose
usually
if the
presented
patient
with
is sexually
endometriosis.
active, we can go for a pervaginal examination, and usually the dermoids are found anteriorly and the endometrioma is always found posteriorly, and pain will be more in endometriomas rather than fibroids, dermoids. Okay, then go ahead.
So MRI is not indicated for all the cases, only for doubtful cases we should go for MRI, and in recent future we might get kits which are based on mRNA for early diagnosis of endometriosis, so that the delay in diagnosis can be eliminated. So physical examination we have already covered. Treatment options for this patient.
Will you prefer medical management or surgical management if the patient has got symptoms?
First of all, we'll go in for the medical management.
Yes.
Because the girl has a long way to go. So initially, we should try non-invasive treatment methods like NSAIDs, OCPs, progesterone, and GnRH is the last option if she is more than 17 years old. Then only we can go in for GnRH. But if the symptom worsens or if she is not responding to the medical management, then only we can go for other invasive modalities.
We can also go for LNG IUS if it is appropriate in the girl.
Yes, that comes as a second line.
Or we can give Dynogest also.
So the first line is, give me one agent which you will like to use.
Which you will like to give as a medical management, first line medical management. One from each panelist.
Dynogest.
You? It is now second line.
One word, what you actually give, because these cases are very
Dynogest 2 milligram daily, because it is most tolerated by the adolescent, less side effect, and it can give it up to 5 years also. And it has no side effect that is with the other GnRH analog or all these.
See, I will ask you one question. Suppose if you are giving Dynogest for 30 patients, how many of them will respond to Dynogest? Because we still see some of the patients who don't respond to Dynogest, isn't it? Yes.
Yes.
Why?
Yes.
What is the reason? So, and what is the what is the other alternative agent?
Yes.
Because we find this very commonly in our clinical practice. because of increased progesterone resistance. Normally itself in endometriosis, there is increased progesterone resistance. It is much more in patients who are not responding to dynages. Okay? So, those are the group of patients whom we should advise GnRH analogs. So, that is clear cut difference. Only 60% will respond to dynages and the rest will need GnRH analogs. Probably if you are starting on GnRH analogs, you can suppress that, and then after initial 3 to 6 months, we can follow up the patient with the dynages. And why oral contraceptive pill is not the preferred first line choice?
I think because of the estrogen content in it.
Estrogen content. You are 100% correct, because it's a estrogen dependent disease and we do not want to pump more of estrogens. Actually what it will do is, it will reduce only the pain when the patient is taking the OC pill, but it will not suppress the disease. But whereas dynages, there are evidences to say that even a larger endometrioma can shrink with prolonged use of dynages.
Yeah, even if patients were dynogest, patients are not tolerating dynogest, you can switch over to dydrogestrone. Even we have sustained release dydrogestrone preparations are available, and patients who are maybe because of nausea and all, if dynogest is not the choice, then before going to GnRH analog, we can try dydrogestrone for those patients.
But just one sec, I want to say that yesterday we heard one talk there in that room that we should in younger age should try OCP first and then we should move to dynogest. So now we are confused as an expert.
Ma'am, actually the ISHRI 2022 guidelines that says OC pills should not be used as the first line in endometriomas, especially in the young girls.
It was told yesterday that in younger age group we should go with OC pill. But now madam is saying no, the newer guideline says, but we are using dynogest.
Yes, because
we are giving dynogest as the first line. If we have any doubts in our mind that it is not dysmenorrhea, it's not going with the drugs, normal drugs, so we suspect endometriosis and then we give dynogest.
Ma'am, in India, if cost is the factor with dynogest, then you might switch over to OC pills, because in OC pills are available free of cost and these are effective. But if we go by evidence which is available, the available recent literature suggests and putting progesterone as the first choice, then the OC pills. But our cultural, our social and economical background has to be taken care of.
So the next option is, if the second progesterone to dynages, we can use dipomethroxyprogesterone as stated. So that is available free of cost in all government institutions, and beyond 16 years we can use it both for contraception as well as for control. Okay. So and that has got of course a slight reduction in the bone mineral density, but still we can use it, because once when you stop the drug, it will come back to normal. Okay.
Implant also we can use.
Yes, implants also you can use. Any form of progesterone, either a DMPA or this one implants. Implants are also being used, but in our part of southern part we don't use, we use only DMPA. Okay.
I think we should hurry up. I will skipping few this.
Implant
So medical management, if taken, we should wait for 6 months to 1 year, and we should follow up the patients with ultrasound for the response.
So these are some of the early endometriotic lesions, and the next picture, usually it is an atypical one. You can see this windows, Allen Masters windows on the second one. You press that. Next one. See, you can see always when you put in the scope, and if you find in endometriosis patient, the peritoneal fluid will be blood stain, and you can, these are all the peritoneal folds. They are called as Allen Masters windows, and they are all the earliest evidence of endometriosis. Then next. Okay. These are the typical findings, and sometimes we can have the atypical findings like that, as vascular spider nevi appearance in the peritoneum. That is also indicative, and even when you do laparoscopy, sometimes we may not find anything and you have to fill some water inside the peritoneal cavity, and you can pick up early lesions. And even histopathology may not reveal endometriosis. Still, if the patient has got symptoms, you go ahead.
So follow up.
How do you follow up? This is go. Just click it, double click it.
How will you follow up with the medical management?
And how long?
After surgery.
Yeah.
No.
After medical management?
You said medical management, no surgical management.
First of all, we'll give her continuous OCPs or continuous Dynogest, and we'll call her first time after 6 months, or even 3 months we can call her for follow-up, then after 6 months, and if she is comfortable, we can give her for prolonged periods, even up to 5 years, or till she wants to fertility, she wants to conceive.
So that's the best one. Continue Dynages, and there are studies which says that you can even continue beyond 5 years. And maybe if the patient is, not affording that much, after initial phase of GnRH followed by Dynages, we can switch over to DMPA. So then when will you do surgery? Just tell
Again, one confusion about the duration of treatment. Yesterday we heard 7 years, and today it is 5 years. Then beyond 5 years. Oh, sorry.
There are studies from Canada where they have used for more than 10 years, and I have personally used it for more than 6 or 7 years.
If she doesn't respond to medical management then, and if the size of endometrioma is growing, then also we can go for diagnostic lab.
Then rupture endometrioma is one indication. Then when you suspect malignancy, and then when it is associated with Mullerian anomalies. So because once when you correct Mullerian anomaly, it will revert to normal.
Become
then
normal.
Any future advice will you give her?
To get married early, basically.
She will not agree.
Then
no woman wants to get married early.
Then
see, that is
you are a IVF consultant.
Oocyte preservation we can talk about.
Fertility preservation, we have to think about fertility preservation. Yeah. So I will move on to the second case. 17-year-old girl was referred to our hospital with a history of lower abdominal pain, severe in pain for the past 1 week, no bowel or bladder changes. Next. Yeah, just one simple or 5 minutes. How will you proceed with the case? She came to me, she was actually referred to me as a case of CA ovary because, next proceed, because her basic investigations, what she has done outside was, CA 125 was, you can see, this girl didn't have any signs of dysmenorrhea, cycles regular, nothing, no family history, nothing. So clinically there was an abdominal mass, and the basic investigations and ultrasound done, and this was the ultrasound picture with an endometrioma measuring 78 into 73, and it was not typical of dermoid. And I did a tumor marker, and the reports of the tumor marker are shown here. CA 125 is 2118. What do you think?
I think we should go ahead with the diagnostic laparoscopy since the
what
tumor
you suspect? What you suspect?
CA 125 is raised. So suspicions is always endometriosis, but also of ovarian tumors, others ovarian tumors. So we must go ahead with
but other markers for ovarian tumor are normal. So
endometriosis chances are higher.
Yeah. Endometriosis, what sort of endometriosis? Other than that, we have so many conditions where CA 125 is elevated. Okay, next. So this patient, next. We suspected endometriosis, and I posted her I wanted to confirm by MRI. MRI also showed the same findings, it is not malignancy. So when I asked, you suggested I did a laparoscopy. Just see. See the laparoscopy, it was a ruptured endometrioma. Bilateral, one side was larger, so it was a ruptured endometrioma, I did cystectomy. Next. So how will you follow up? The AMH should be done for this patient, isn't it? Because we have to tell her regarding this. And follow up, how will you follow up the patient?
Since her CA 124 was raised, so we should follow her with the CA 125 value. And also with ultrasound, we can call her 3 monthly or 6 monthly, depending upon her symptoms.
So the ultrasound that was done after 6 weeks was absolutely normal. And when we do any surgery, the recurrence, what is the incidence of recurrence? It can happen to
High chance of recurrence in case of endometriosis.
20% after 2 years and 50% after 50 years. So that is why we
counsel
have
the
to put the
patient.
patient on constant suppressive therapy. So this again we have discussed earlier. Next. So the same patient came back to me after marriage, and you see the beautiful, I did a section for her, see the beautiful ovaries. It was absolutely normal, I think. Conclusion, yeah. So now, because we are lagging time, adolescent endometriosis, to say it should be managed only medically, and what should be the drug? Oh, just you show the picture of that Mullerian, yeah. Show that. And in the presence of any Mullerian anomaly, we have to go in for a surgery. So this was a patient with the 2 horns and 1 horn obstruction. Go back. This was another patient where there was a hematometra, and this is a case of Hurlin-Werner-Wunderlich syndrome where we did a hemihysterectomy, followed up the patient, and then she had a beautiful normal delivery. See, here we can see the absence of ipsilateral kidney. Okay, so now let us come to the conclusion. 1 point from each. Quick 1 point.
Dysmenorrhea in adolescence should not be ignored. There should be high degree of suspicion.
Any girl presenting with dysmenorrhea which is affecting her quality of life, she should be treated.
If any of the girl that present with progressive dysmenorrhea, it should be properly evaluated at time to prevent. At least you have from every aspect, for every gynecologist, you must be endometriosis aware.
Okay, any adolescent girl coming with dysmenorrhea, she should be evaluated for endometriosis.
Can I?
Yes, madam.
Any adolescent girl coming with pain for last 6 months, which is progressive, we should exclude endometriosis before proceeding anything. And pain should be the first thing to manage. This I have learned today, that you must give medicines for pain and make it. Otherwise, it will be more, and her quality of life will be very bad later.
We would have commonly seen neonatal uterine bleeding.
Yes.
That is found to be a predictor for endometriosis. So when you see a girl, when you deliver a girl child who has day 3 neonatal bleeding, warn her mother that she is a candidate who is likely to have endometriosis. Actually, I have picked up in one of my IVF patients, Hurlin-Werner-Wunderlich syndrome in utero for the baby. I have warned the mother. I have asked her to come after 7 years. The girl is slightly matured. This I delivered some 3 or 4 years back. So I think.
All right, ma'am. So I would like to thank the moderators, the expert, the panelists. Thank you so much, and you can come down here for a group photograph. Meanwhile, may I invite
our experts, panelists and audience for this panel. Thank you so much.
All right, for the next session, I would like to invite our chairpersons on the dais, Dr. Rajshri Purbe, Dr. Usha Agrawal, Dr. Neelam Kumari, Dr. Sunita Kumari, and Dr. Dayanidhi. And we have our first speaker here, a very well-known personality on the dais. Dr. Ritu Khanna is already here. So, the chairpersons, we already have the CV on display. So let's give more time to Dr. Ritu Khanna for her presentation.
Yeah. So, can I start?
We are starting with 2 sessions. First is Dr. Ritu Khanna, by Dr. Ritu Khanna. She is
Ma'am, her CV is already there displayed, so we can start with her time.
Yeah.
So that she can deliver
thank you so much,
our
and my
talk.
heartiest congratulations to Supriya and Dr. Meena and the whole vibrant team
for having me also here for this grand event. So with this, I begin with PCOS management, whether you should go for a lifestyle or drugs. We know it's much more in 18% women of the reproductive age group. And if you look into the global prevalence, we'll find it's 2.2 to 26%, a huge range, you know. And 2 in every adolescent suffer from PCOS. And why is this huge range? Because we use numerous definitions. And also, if you peep into the country, it differs with ethnicity, environment, nutrition, and also your genetics. So, it's since 1935 we are going around with so many definitions, and what we follow is a Rotterdam criteria. And then came up the NIH evidence group, which said, yes, you need to clearly define the phenotype of PCOS, and so came the ultrasound. We know that we do not use it for the diagnosis, but the ultrasound was used to complete the ovarian, the morphology, so that you can classify your phenotypic classification, which will help in the management. So once you put in all the features of hyperandrogenism, ovulatory disorders and ultrasound, you clarify them into whether they are phenotype A, B, C or D. But what was the need? The need was because the A and B are the classical, and they are the ones which are going to trouble you. You need to follow for the metabolic risks also. But approximately 50% of the affected women were overweight, and it demonstrated that they have much more visceral fat tissue than that of a BMI of them. But why does this adipose tissue trouble us? It's because it's just going to mimic an endocrine organ. And the leptin, which is there, the high level, reduces the androgen to estrogen conversions over there, and adiponectin reduces insulin sensitivity. So we get troubled by these patients of getting a follicular atresia, and so modulation of so many hormones keep going on. So you have an insulin resistance, you have obesity, then you have an hyperandrogenemia, and look at this, the vicious cycle keeps going on. So unlike other concerns with other medical conditions, which have an intersection of reproductive and metabolic hormones, and the same is with PCOS. So it does not leave even the lean ones too, because it's found that insulin resistance is present in women of PCOS independent of the body mass index. So what we do now is, we were measuring the BMI, but BMI has its own limitations, and it has been found that the visceral mass, it is much more important, and therefore we measure the waist circumference, and we take the waist hip ratio, which is much more important over here. So reduction in insulin resistance stands as the key, and the principal goals of management stand as your lifestyle. But what does the lifestyle mean? It not only means a physical activity, but it incorporates your diet, and along with it also your weight loss 5 to 10%, apart from the other modifications that you're going to do and will come across. So we have a regular exercise and the healthy diet over here. So you ask the woman to stop smoking alcohol and caffeine, because that was lowering the estrogen and increasing her androgen level. You tell her to exercise if 18 to 64 years, or 150 minutes of a moderate and physical, or a 75 minutes of vigorous activity, and the adolescents are told for allowed 60 minutes of the moderate to vigorous intensity of physical exercise. So if a woman says, or a girl says, yes, I do a lot of work at home, but that does not complete it. You need to have 10,000 steps, which include your structural physical activity, or even the 3,000 steps of whatever activity you were doing at home. So everything has to be very smart. You start with 10 minutes of bouts and increase 5% weekly. We always say 10% of weight reduction you do and come back, but does it happen? No. Do not worry. Even if you do 5% of reduction in our BMI, it really, wonders to your glucose dynamics, and 60% of them return with the menstrual cycles coming to normal, and they start ovulating too. If you look into this chart and you see the weight reduction which is done, that so many ovulated and became pregnant, which really becomes a boon for these patients. But does that alone do? No. You need to have an energy deficit, and that stands as 350 to 1000 kilocalories. But how do you find out whether how much of energy deficit are you going to do? It stands if you're a sedentary, you're a moderate, or you're a very active worker. And that is, if you're just doing your activities, you're a sedentary. If you walk 1.5 to 3 miles, you're moderate. And if you walk more than 3 miles, it stands as an active worker. So you calculate your calories, and at least 200 kilocalories per day need to be going into deficit. So energy deficit of 30%, low caloric diet, that's 500 to 750 kilocalories per day. Not only this, her diet needs to be planned. If you go on the right, it's the amount of carbohydrates, fats and the proteins you're going to take, and on the left is the timing. It's the timing that she needs to adhere by. It's 9, 11, 1, 4 and 8. She needs to stick to this timing, because if should not give longer gap into her meals. Insulin resistance can cause high blood sugar levels and can raise your appetite and can cause you to crave for sweets, and you crave and you have a lot of weight gain. So what does she do? She takes her meals at around 4 to 5 hours of interval. Skipping meals, they say, I don't eat anything. But does that do? No, not at all. If she skips meal, there will be more insulin rises. So she needs to have 2 snacks and 3 meals together. And yes, she needs to have 3 food groups in her meals and 2 food groups in her snacks. And if you don't eat a skipped meal, it leads to an over-hungry situation and you're going to overeat rather than undereat. So blood glucose, insulin go more hand in hand, and that's why you adjust your carbohydrates to 25 to 30%. And it's, you know, what you take is a whole fruit or a whole unprocessed food. That's what is going to benefit over here. The more you process the foods, the more you're going into having more of insulin demands over here. So refined carbohydrates to be avoided. Fiber content in the diet needs to be very good. So it's going to avoid your constipation and clearance of all the toxins and eliminate all the toxins from your body over here. So this is your food pyramid. Fats and oils taking just the tip and the base with the grains and the vegetables over here. Now she may be an adolescent PCOD or she may be going to an anovulatory PCOD. Girls worry standards, acne, hirsutism, obesity, but doctor worries for infertility. And for an anovulatory, the woman worries for infertility and all, and the doctor is concerned more with the oocyte quality and what she's going to give. So that means the insulin resistance stands as a primary cause in PCOS. And what do we do if she's an adolescent? We manage the irregular cycles and we ameliorate the hyperandrogenic features. If she's reproductive age, we do an ovulation induction. If no ovulation induction, she doesn't want to get pregnant, you go for a contraception. And of course, she is an elderly, then you manage the metabolic, and you're more concerned for her endometrium hyperplasia or the carcinoma. So you reduce hyperinsulinemia and normalize the LH ratio. And how do we do? We already know that the adolescent girls, we modify the dietary habits, and of course we put them with COCs, with cyproacetone, drospirenone, which are more effective. Ethinyl estradiol, not more than 35 micrograms, and anti-androgens stand as the second line. But insulin sensitizers sometime may be noted. And what are the patients? These are needed when they have irregular cycles or they have hyperandrogenism, they've got a lot of obesity, BMI more than 25, and your lifestyle and all are not going to work. And that is where you're going to put them into insulin sensitizers. But never leave their follow-up. Just keep following and motivating for a good lifestyle. Now, if she's goes into a reproductive age group, you need to do an ovulation induction. And as per the international evidence-based guidelines, letrozole stands as a first therapy and clomiphene, but you'll find on the other hand, you needed to add some insulin sensitizers, and the patients would be those with BMI more than 25, not responding to any lifestyle and all chances over here. So those who are obese, who are clomiphene or letrozole resistant, and you require a reduction in the OHSS of these patients who are going, these are the patients who have had a lot of recurrent early pregnancy loss. They need to be put on insulin sensitizers, so you use your drugs. Insulin is the key opener to these, and what insulin does it binds to the receptor and forms a complex, and that is an IRIS complex, and this complex stimulates the PI3 kinase and cyclic AMP, and that in turn stimulates the gluton 4, and also glucose is thus taken up, and this glucose 4 through the glucose demands for utilizing energy, and then this receptor goes back to its own position. So this is what happening. But this PI3 kinase needs something, it's a key messenger, and inositol is proved to be the precursor to this. We find it in fresh fruits, vegetables, and therefore the foods containing seeds should always be consumed. There are 2 isomers of this inositol. One is the myoinositol and the G0-inositol. Both belong to the sugar family and they act at the peripheral level. We know the MCI-DCI ratio needs to be 40:1, but do not forget that for a follicle we need this ratio to be 100:1. So myoinositol is able to promote the glucose cell intake while DCI stimulates glycogen synthesis. And then there is a conversion from the myoinositol to the D0-inositol by an enzyme which is epimerase, and this enzyme is totally insulin dependent. So when there is a hyperandrogenic state, what happens is this enzyme gets activated and more of myoinositol is going to be converted, and you're going to have a deficit state of myoinositol. Moreover, these PCOS patients have 5 to 6 times more urinary clearance of the inositol. So in turn, they're going to be deficit of inositol, and therefore your ratios are going to be affected, and there's going to be a compensatory hyperinsulinemia, and you get all imbalances, ovulatory dysfunctions, and everything that you're seeing. And moreover, when there's more of epimerization, what happens in your follicle, myoinositol decreases, and therefore you get these patients that do not respond well when you're going to stimulate them. There's going to be an impaired FSH signaling, so you get very poor quality of oocytes with them. The clinical supports over here are, if you've given a patient, she is very obese, you've given her alone myoinositol and you give a combination, with combinations they respond better. And if you give a combination and you look at the metabolic effects that they're going to have, the MIDCI group respond better than only myoinositol group as response to the metabolic diseases. Also, if you're improving the IVF outcome in these patients, use a combination which better stands than alone a DHA or inositol, because myoinositol is required into the follicles also. So you will get less of degenerated oocytes, you'll get a better fertilization rates in these patients. But still is something missing out of the prescription that we're making for these PCOD patients. And that stands as a very important factor which goes unaddressed is a peroxisome proliferative activated receptor delta. Especially the delta receptor is, enhances the fatty acid metabolism. Where do we find this? It's in the adipose tissue we were worried about, it's in the skeletal muscle, it's in the liver, it's in the skin. Now what does this delta receptor do? If you activate it, it's going to increase the thermogenesis in the adipose tissue, enhance the fatty acid metabolism, and therefore all your adipose mass is going to move and it's going to decrease, and you wanted this. But this receptor is sitting, it needs somebody to activate it, and that activator stands as vitamin D. So if you give vitamin D, it's activated and your adipose tissue mobilization, so that's going to do wonders for your patients of PCOS. So reducing insulin resistance and managing obesity, we have a lot of evidences for vitamin D standing as a good supportive evidence to put in these patients. 85% would be deficit in vitamin D and 50% would be deficit in inositol. So you have an enzymatic way and you have a receptor way which takes you through and manages all your insulin resistance and obesity. Folic acid, yes, we know it's important for reproduction. Do give supportive folic acid, and that also give it in an active form, because they're unable to convert the inactive to the active form, and that's why they will stand as deficit. And if they compared 1 and 5 milligram, they said 5 milligram is much better. Another molecule which stands as alpha-lactalbumin, what it does is, it's going to bind to your myoinositol. So it's going to facilitate this passage to the intestinal barrier, and it's an anti-inflammatory molecule. We know that PCOS today is a chronic inflammatory disease, and therefore this molecule helps to, improve the inflammatory conditions, and therefore if you combine, your patients are not responding to the combination, you add this molecule, which the drug which contains alpha-lactalbumin, and they start responding within the next 3 months. So the combined effective therapy is much, much better. Oxidative stress, yes, for this we need to add minerals to the prescriptions of magnesium, zinc, chromium, which decreases insulin resistance, improves your health of ovum. So this was just the tip of iceberg, and we really need to consider the metabolic risk that they really stand. And now it's a changing paradigm. PCOS changes from the reproductive to a metabolic disease, and of course if they have any history of obesity, cigarette smoking, dyslipidemia, they may be at risk of cardiovascular disease, so keep following them, and therefore your best therapy stands as a 360-degree approach to the problem, taking the complexity of the syndrome. So thank you so much for a very, very patient hearing. Thank you. Thank you so much, ma'am.
Our second speaker.
We have to switch it on. Switch off हो गया आपको switch off.
Our second speaker is Pragati Bharti from Indra IVF Center. Ma'am, please come. She is consultant gynecologist in IVF Center, Indra IVF Patna.
Thank you, ma'am, for the kind introduction. Good afternoon, everyone. I am honored and privileged to present this important topic today. Now, adolescent, the World Health Organization defines an adolescent as any person between the age 10 and 19. In India, above age group makes up 20%, 21% of the population and accounts for 253 millions, necessitating a focus on adolescent healthcare. And with the increasing trends in infertility, it is crucial to address health issues in adolescence that may impact fertility in the future. By investing in comprehensive adolescent health services, we can better prepare our youth for healthier reproductive outcomes. Now, adolescent issues which impact the future fertility can be further divided into gynecological, oncological, and behavioral and social factors. Coming to the gynecological problems, an adolescent with gynecological problems should be approached with sensitivity and care, ensuring that they can share their concerns without any hesitation. For instance, the movie OMG 2 highlights the importance of creating an open and supportive environment for discussing sensitive issues, encouraging adolescents to speak up and seek help when needed. An individualized, well-organized and effective management important. Now these issues are already been discussed. Some factors, some menstrual factors like primary amenorrhea, secondary amenorrhea, dysmenorrheas, infections like PID, sexually transmitted infection, and various ovarian masses affect future fertility. Starting with primary amenorrhea, there are various causes like hypogonadotropic hypogonadism, chromosomal anomalies, autoimmune diseases, iatrogenic causes like radiotherapy, chemotherapy, Mullerian tract defects, environmental factors, and there are some idiopathic factors also which affect the future fertility. Now the management of these primary amenorrhea causes depends on the causes, patient health status, psychological concerns and goals. For example, hypothalamic hypogonadotropic hypogonadism, we need to give the hormone replacement therapy and to diagnose the cause and treat it accordingly. In hypogonadotropic hypogonadism like in Turner and Mosaic, hormonal therapy along with counseling about its effect on future fertility is required. Coming to Mullerian tract defect, some defects like imperforate hymen, it can be solved with a cruciate incision. Transverse vaginal septum can be solved by surgical removal of the septum, but in case of cervical hypoplasia or absence of cervix, it is difficult to treat. Now some autoimmune diseases like diabetes mellitus, hypothyroidism, Hashimoto thyroiditis, Graves' disease, they are common disorders which are associated with primary amenorrhea. Along with this, some chromosomal anomalies are often one of the major causes of amenorrhea in India, including BMP15 mutation and FMR1 pre-mutation, which gives Fragile X syndrome. They have been detected in 10% of adolescents with primary amenorrhea. Now coming to the secondary amenorrhea, as we all have discussed before, polycystic ovarian syndrome is diagnosed in 80% of the cases of secondary amenorrhea. There are some other causes like hypothyroidism or hyperthyroidism, hyperprolactinemia, but it accounts for 80%. PCOS accounts for 80% of the cases. It manifests like irregular menses or androgen excess signs like acne, hirsutism. An elevated LH serum level with normal or low FSH generally characterize PCO. Now, PCO diagnosis in adolescents is challenging due to several factors. Like we have overlapping symptoms, there are variability of the symptoms, there is lack of standardized diagnostic criteria. Also, there are hormonal fluctuation. Along with that, adolescents may be reluctant to discuss symptoms like menstrual irregularities, hirsutism due to embarrassment or lack of awareness, which further delays the diagnosis. And also they have limited awareness and education. But adolescents having PCOS do not need to be infertile in their reproductive age. This is because they ovulate spontaneously. However, the ovulation frequency is not certain. But a study reveals that women with PCOS ovulate 32% of their whole reproductive age. Thus, PCOS is a common condition that have long-term complication, and if left undiagnosed and untreated, it will impact the fertility also. So in this case, early diagnosis and quick treatments can improve the life quality and the fertility of adolescent female. Healthy lifestyle habits like eating healthy, nutritious food and physical activity should be promoted in adolescent with PCOS. Now coming to dysmenorrhea, endometriosis is the leading pathological cause of dysmenorrhea and chronic pelvic pain among adolescents. Our goal of therapy should be symptom relief, suppression of disease progression and protection of future fertility. Therapy must be individualized and medical treatment should be preferred over the surgical one. We should consider patient choice, the need of contraception, contraindication to hormonal uses, and potential adverse effect of the drugs, and counsel the adolescent and her family on treatment option also for early marriage and early pregnancy. Now coming to ovarian masses. Ovarian masses and tubercular masses are one of the leading cause which impact the fertility in adolescent. For this, we need early diagnosis and we need to manage according to the cause. For example, the tubercular masses like TB in adolescent can affect cervix, uterus, tubes and also the ovary. Along with that, abdominal peritonitis and adhesion which may lead to frozen pelvis. In males also, there may be structures, ulcer, epididymis, scrotal swelling, hydrocele and some infection which can affect their fertility as well in males also. Now coming to pelvic infection and sexually transmitted infections. Chlamydia and gonorrhea are the leading cause of pelvic inflammatory disease and often asymptomatic, leading to delayed diagnosis and treatment. PID is the infection of upper reproductive organ and cause damage to the fallopian tubes, ovary and uterus. Also it increases the risk of chronic pelvic pain, ectopic pregnancy and infertility of course. How can it impact on infertility? It can damage the fallopian tube resulting in scarring and blockage. Also it may lead to ectopic pregnancy due to damage and scarring of the tubes. Also up to 10 to 15% of women with PID experience infertility, which is a large number. Now how can we prevent this? Early detection and treatment is the key. We need regular screening for STIs, especially in sexually active adolescents. Prompt treatment of infection to prevent progression of the PID. We need to educate and aware the adolescent about the safe sexual practices, HPV vaccination to protect against the human papilloma virus, which is a common STI, and we need to give them a proper access to healthcare, providing adolescent with easy access to reproductive health services. Confidential and adolescent-friendly healthcare environment can encourage them to share their concerns. Now coming to the oncological issues. Infertility is an important late effect of cancer therapy and it typically occurs year after the completion of treatment and often after the patient has transitioned from the pediatric survivor care. Now, why in case of oncological patient there is risk of gonadal dysfunction? Because there is exposure to traditional alkylating agent chemotherapy like cyclophosphamide, heavy metal chemotherapy, along with that radiation, abdominopelvic exposure to radiation or cranial radiation more than 30 gray which may impact pituitary and hypothalamus also. Along with exposure, we have surgeries like in many oncological ovarian masses, we need to resect the ovary. So surgeries on reproductive organ is one of the cause because in many cases we need to save the patient first. Along with that, hematopoietic stem cell transplant, reparative regimes, like in case of bone marrow transplant, we need to counsel the patient about the fertility preservation. Now, counseling is the key. Fertility sparing surgeries should be promoted whenever possible. We need to promote gamete preservation like ovarian, testicular tissue preservation or oocyte cryopreservation. Now, coming to the male counterpart, Males who receive gonadotoxic therapy may have loss of spermatogonial stem cells. But for those who are able to produce sperm after the completion of treatment, do not have the same risk of early senescence of germ cell production that their female counter cancer survivor experience. Proper counseling should be done and option of sperm preservation should be given to all adolescent cancer patients before starting their chemotherapy or radiotherapy. Now, what challenges do we face here? Infertility after childhood cancer therapy typically occurs. What challenges we face here? Because when patient is suffering from cancer, he wants to survive first. He doesn't think about the fertility preservation at that time. Now, coming to behavioral and social issue, there are various factors like drug, alcohol intake, stress, depression, anxiety, unsafe sexual practices, teenage pregnancy, and unsafe abortion, which can damage the fertility potential of the adolescent. Early unwanted pregnancies and abortions can damage the uterine cavity, leading to further secondary infertility. Now, coming to the take-home message, like there is growing concern about the gynecological problems in adolescents as they may affect reproductive competence. Early education and awareness program should be conducted for adolescents along with regular health screening. Counseling and mental health support is necessary. We need to promote healthy lifestyle among adolescents. We need to give them access to reproductive health services and referral of adolescents from oncologists and other doctors in adolescent well-organized clinics to fertility professional is of great importance to preserve their fertility. Multidisciplinary and individualized management is considered necessary. Again, proper counseling of both adolescent and parent is the key. Thank you for your patient listening.
Thank you, Pragati Bharati, for your nice presentation. You have covered all the topic very well. Thank you once again.
Thank you, ma'am.
I would like to thank the chairpersons, and I request both our speakers and the chairpersons to please join us for a picture, and we have the memento. Ma'am, Pooja ma'am, come please this side. And we quickly go ahead with the next session. I request our chairpersons to join us on the dais. Dr. Lata Shukla Divedi, Dr. Sujata Chaudhary, Dr. Pratibha Prakash, and Dr. Swapna Jha. May I request all our esteemed chairpersons to please join us on the dais. And we have our speaker as well. Our speaker is already here. We have Kanak Priya Tiwari. So Dr. Kanak Priya's CV is already here. So we request our chairpersons to please grant the permission to start with the presentation. The slide is moving.
Hello. Yes. Thank you so much, first of all, to the organizing team for giving me this opportunity. And when I was asked to speak on Turner syndrome, I actually thought, what will I speak for more than 10 minutes on this? But then I went down the rabbit hole and almost had an existential crisis. So we're all aware. I'll be keeping it brief and quick and cover as much as I can on Turner syndrome. So the most common form of sex chromosome aneuploidy in women is Turner's. We're all aware of the XO karyotype. The incidence is 1 in The incidence is 1 in 2500 to 1 in 3000, and almost 1 in 10 of the first trimester miscarriages are fetuses with Turner's, and unlike Downs, it's not related to maternal age. Now, when we come about to the karyotyping, suppose we have there's the classical Turner where all of the cells are having an exo karyotype, and then there's the mosaic variant where some of the tissue is having exo, some of them is a normal karyotype. So if we have a patient coming to our OPD, clinically looks very much like Turner, we've got a blood karyotype done, it's normal, but we still suspect it, it's better that we send tissue from the other sample as well. Now rarer karyotypes, nothing that we really have to study in detail as gynecologists, but there are certain clinical implications that I'll get on as we move on. So as we know that lionization where one X chromosome is inactivated, it is seen in normal karyotypes, but since in Turner's there's only one chromosome, this is the only monosomy that is compatible with birth. As far as diagnosis is concerned, so 25% of these patients or babies are diagnosed prenatally or in early childhood. As far as the prenatal diagnosis is concerned, you can see this ultrasound picture that there's a lymphedema, cystic hygroma that we can see, as well as in the early childhood, we can see such webbing of neck, lymphedema of the feet. This is a classical picture, but the problem lies in the age group from 6 to 10, where the only finding that is clinically seen is reduced height. So it is important to pick it up at that point. Now we are all aware of the clinical features, but just to keep it easy, there are certain mnemonics. It might be a little offensive to use this mnemonic, which is subclown, but yes, there's short stature, sensory neural hearing loss, amenorrhea, bar body absent, cardiac anomalies, lymphedema, streak ovaries, web neck, widely placed nipple. Along with that, there are certain renal anomalies and facial features as well. This is a beautiful screening test that RCOG has given in its TOG article on Turner's. I'm covering it on as we move. You can find it on the TOG article itself. Coming on to ovaries, in cases of classical Turner's, we are able to see the streak ovaries as you can see in the picture. Now in mosaic Turners, they are the ones who mostly end up having spontaneous menarche. But due to the accelerated atresia of the follicles, these are more prone to develop premature ovarian failure. As you can see this laparoscopic picture as well. Before 12 weeks of gestation, the ovarian development is normal. It is later on that the accelerated atresia is what we see. In uterus, if it is a classical Turner's, we will be seeing infantile measurements, but if it is a mosaic variant, we might see a normal uterine growth. Coming on to cardiovascular system, this is very important because it directly affects the morbidity and mortality of the lady, and highest risk of aortic dilatation and dissection is seen. Almost 30% of Turners present with bicuspid aortic valve, 12% come with aortic coarctation, and both of these conditions predispose to aortic root dilatation and aortic dissection. Now, important thing here is that we have an echo report in front of us. Most of us generally just have a look at the ejection fraction. We don't look at the aortic root diameter. And in Turners, the aortic root diameter needs to be corresponded to their height because they're generally short statured. What might be a normal aortic root diameter might be abnormal for Turners. So a good rule is maybe more than 20 mm, they are more prone to develop aortic dissection. A screening protocol, yes, if we get a cardiac MRI or an echo done, if it is normal, we can keep them for an annual or 5-yearly follow-up. Annual if they are planning fertility, 5-yearly for their general health. Otherwise, we go along as per the cardiologist opinion. Hypertension seen in almost 1/3 to 1/2 of the women, and it is independent of the cardiac anomalies that they have. And also for hypertension, we need to use ideally a height-based normal value because a 120/80 blood pressure in maybe say a 120 centimeter girl might also be abnormal. So a good idea is target systolic BP should be less than 140 if the aortic valve is tricuspid, less than 120 if it is bicuspid. Renal anomalies seen in almost 1/5 of the women. As such, they do not show any symptoms, but collecting duct obstruction can occur commonly. Thyroid antibodies are also very commonly seen in Turners. Now, thyroid antibodies as such don't have a problem, but if the woman, if she's healthy throughout her life and goes into her advanced age, then they are more prone to develop other associated anomalies with thyroid. Coming on to GI system, isolated elevations of SGPT, SGOT are common. They don't really have any clinical importance, but because these women are more prone to develop metabolic syndrome and obesity, we need to keep an eye on fatty liver. Also, the RCOG has said that every 5 years, screening for celiac disease should ideally be done. And learning is a little complex. Before 10 years, they are more prone to have conductive hearing loss. After 11 years, some of them end up having sensory neural. So when these young girls come to us in our clinic with their mothers, it is important that we advise them that they should be trained in sign language early on. And because of these disabilities, they too tend to have ADHD and autism-like effect as well. Now, coming on to the management, the first thing that Turners and their families are concerned is first height, second is their puberty, third is fertility, and fourth is if they at all become pregnant, then what is the course of pregnancy. So for height, it is mostly the pediatric endocrinologists who are involved, where we use growth hormone. Before, it was speculated that if we use growth hormone and estrogen together, it is something that we should not do. But now, if we are starting with estrogen at a very low dose, maybe say around 8 mg, or at an earlier stage, it doesn't affect with growth hormone. We would generally avoid using growth hormone when it is detected, say around 13 years or 14 years of age, because that is when our primary concern is to induce puberty. Now, it has been noted that the average BMI, total body fat and abdominal fat is way less when we are using growth hormone, so it should be incorporated. There is 100% safety of growth hormone, does not affect the heart, there's no cardiomegaly unless, unless there was previously there was a theoretical risk that because of the effect of growth hormone in acromegaly, it might hamper the heart. As far as the puberty induction is concerned, the protocol is same as we use for general people. This is a very nice scientific impact paper by RCOG. Very simple, very brief, very crisp, to the point. So ideally we should start at around 2 mg of microgram of ethinyl estradiol at 8 years, gradually increase the dose. Once we have had a sufficient cover of unopposed estrogen or breakthrough bleeding occurs, then we start with progesterone. So estrogen, previously we used to use ethinyl estradiol. Nowadays transdermal is preferred because it is showing better results on blood pressure and bone health. Progesterone, we would try to avoid norethisterone. Micronized or medroxyprogesterone should be used. As far as road to parenthood is concerned, so it is important to remember that mosaic karyotypes particularly, they still have a chance of having spontaneous pregnancy. Around 8% of them may conceive naturally. However, the risk of miscarriage is very high. And even those in whom we are using oocyte donation, the risk of miscarriage is higher as compared to other normal peers because of the suboptimal uterine growth. As far as inheritance is concerned, there is, we can reassure them unless there is deletion of X chromosome or there is a ring X chromosome. In that case, there is chances of transferring it to the next generation. The ART specifications, now suitability for fertility preservation, the criteria is same as normal people, which is spontaneous menarche is there if you are able to see at least one normal ovary, or FSH is less than 40. AMH is a good and reliable marker. As far as the diagnostic parameters are concerned, again, AMH, FSH, karyotype, spontaneous puberty, ovarian volume, follicle count, these should be included. Oocyte cryopreservation, lots have been spoken about. As far as mature oocytes, when we want to have M2 oocytes for us, the problem here is that clinical pregnancy rate is around 5% only per oocyte, and in these women, because they already have very less follicles, we need to give multiple cycles at a very young age. So they need to be realistic expectations with parenthood. And ovarian activation in vitro as well as ovarian tissue cryopreservation has been done in women with Turners. The problem is that once we take out the ovarian tissue, we keep it, we mature it, and if we transplant it back, again the atresia starts at a higher rate. So, so that's why we should ideally give them some angiogenic and anti-apoptotic factors as well in their culture media. Oocyte donation, 75% of women do opt for that. Success rate is almost 37%. There has been one case study, it's from Israel, where a mother froze her oocytes and then they were donated to her daughter with Turners. But there's a lot that can be debated on the ethics of this. As far as surrogacy and adoption is concerned, we're all aware of the new surrogacy and adoption laws. Single women can have a surrogate pregnancy as well, but they need to be either widowed or divorced or more than 35 years of age. As far as pregnancy in Turner's is concerned, the most lethal risk that can happen is aortic dissection and sudden death. So one should ideally include an aortic MRI performed within the year prior to conception or planned fertility treatment. When the findings, when the findings of this are normal, then we can do it every 5 years or as per required. The most dramatic risk, like I said, is of aortic dissection. Third trimester and early postpartum is when they are most prone. Ideally, they should be delivered in a center with a cath lab and should be discharged only after 7 to 10 days, because that is when the dissection can happen most commonly. Contraindications of pregnancy, French guidelines have given very clear cut that absolute diameter should be less than 35 millimeter, no history of aortic surgery, and there should not be any uncontrolled hypertension. Only then we can go for a pregnancy. ACOG says any problem, don't go for a pregnancy.
Yeah, if you can go to the concluding slide. Yep.
Okay. So with that, I'd just like to conclude my talk because we're running short on time. But thank you so much for your patient hearing, and thank you.
Right now we invite our last speaker before the lunchtime.
Oriented presentation. Now the moment has come to discuss one of the most important topic, eating disorders. Eating disorders in adolescent. Now I request and invite Dr. Anju Turier ma'am.
Ma'am, you can hold the mic closer to you.
Her expertise through her insightful presentation. Please, Anju ma'am, please.
Dr. Anju. All right, so this is going to be the last presentation before the lunch hour.
Hello.
And Dr. Manju, over to you.
Thank you, Pratibha, and thank you the organizer. And thank you all the organizers for having me over here. Today my topic is eating disorders in adolescence. The very word adolescence indicates a very vulnerable period of a person's life. This is the time when an adolescent is exposed to both good and foul elements of our society. Adolescence word comes from the Latin word adolescere, which means to grow up. This is a unique stage of human life between childhood and adulthood, and according to WHO also it is 10 to 19 years, and is an important time to lay the foundation of good health. This is a transitional stage of rapid physical, cognitive, psychological growth and affects how they feel, think, make decisions and interact with the world around them. At this point of life, they are extremely curious. Okay. Now this is a serious behavioral condition affecting millions of people worldwide. These conditions go beyond preoccupation with food and weight, impacting one's physical, emotional and mental being, making it difficult to cope with daily life. They are included in the global burden of diseases, posing a concern in most of the middle and high income countries, as the prevalence in young people has markedly increased over the past 50 years. And according to a study between 1990 to 2019, eating disorders are included amongst the most life-threatening of all mental health conditions worldwide. Now it is defined as a group of behavioral conditions characterized by insufficient or excessive or peculiar pattern of food intake. The body dissatisfaction related to overvaluation of the thin body as ideal. It is associated with dysfunctional patterns of cognition and weight control behaviors and result in significant biological, psychological and social complications. Etiology is mainly it is in the mid to late adolescence, and this is the peak period of eating disorders. Both girls and boys, especially in case of actors, social influencers, models, athletes and dancers, especially ballet dancers, feel pressurized to be fit physically and look a certain way which can influence the development of eating disorders. All the time they feel that they should not be eating. Their mental status is as such, that is, I am forever engaged in a silent battle in my head over whether or not to lift the fork to my mouth. These disorders impact all aspects of a person's life and relationship with the family members, friends and co-workers. Even the functioning in academic settings and workplace, it can even make it impossible to lead a normal life. 20% of all adolescents suffer from eating disorders and 22.3% more girls suffer from boys. And 23% of our Indian population are adolescents. Some adolescents, due to fear of gaining weight, use extreme measures to limit food intake or food groups when they feel that other aspects of their life are hard to manage. These are the factors influencing adolescent health: the parents and families, schools, social norms, healthcare system, employers, faith communities, community organizations, media, government policies and laws, neighbors and communities, peers and sample texts. Interpersonal relations for this are troubled family and personal relationship, difficulty in expressing emotions and feelings, history of being teased or ridiculed based on size or weight. There is history of trauma, sexual, physical and or mental abuse. And 60 to 78% of all bulimia nervosa patients have a history of physical and or sexual abuse. Now we come to classification. The classifications are anorexia nervosa, bulimia nervosa, restrictive food intake disorders, binge eating disorder, eating disorders not otherwise specified, obesity and pica. The term anorexia nervosa was established in 1873 by Queen Victoria's personal physician, Sir William Gull. This is a Greek term with a prefix and denoting negation. Anorexia means meaning appetite, thus translating to nervous absence of appetite. So in nutshell, anorexia nervosa is a disorder characterized by fear of becoming fat and refusal of food, leading to debility and even death. Isabelle Caro, a French model and actress, became the international face of anorexia when she allowed her ravaged body to be photographed nude for an Italian advertising campaign to raise awareness about the disease. She died at an early age of 28 in November 17th, 2010. This is the picture of the this is the picture of the French model. Now, etiology. The predisposing factors are biological, genetical, socio-cultural and environmental. The precipitating factors are nutritional deficiencies, life transition, family problems or tensions, stress, media, low self-esteem. The perpetuating factors are also ongoing low self-esteem, ongoing stress and ongoing family tensions. All these come up to eating disorders. Bulimia nervosa also comes from a Greek word, which is ox means X and limos means hunger. It is marked by uncontrolled episodes of overeating called binging, followed by purging by self-induced vomiting or misuse of laxatives, etc. It is potentially a life-threatening disorder. And now we come to the difference between anorexia nervosa and bulimia. These are two main important anorexia cases. In anorexia nervosa, we have low weight, where it's normal in bulimia. Anorexia nervosa presents early, bulimia presents late. In anorexia, patients rarely seek help, but bulimia patients do. There is an early onset to middle teens, and in bulimia, onset is late teens. Anorexia can be premenarcheal, bulimia is rarely premenarcheal. Anorexia affects both boys and girls, and bulimia usually affects the girls. Anorexia can be acute or chronic with no previous illness. Is associated with anxiety, obsessive compulsive disorder and depression. And there's poor prognosis without early intervention. In bulimia, the course is quite fluctuating and usually has a previous history of anorexia nervosa and is associated with depression, self-harm, substance misuse, and up to 60% respond to specific treatments. Now the diagnostic criteria. In anorexia, the body weight is maintained at least 15% below that of the expected body mass index. And weight loss is self-induced by avoidance of fattening food, plus one or more of self-induced vomiting, self-purging, excessive exercise, and use of appetite suppressants or diuretics. In bulimia, there is persistent preoccupation with eating, overeating episodes in which large amounts of food are taken in short periods of time. The patient tries to counteract the fattening effects by one or more of the self-induced vomiting or purgative abuse, alternating starvation and eating, and use of appetite suppressant, thyroid preparations or diuretics. In anorexia, the body image distortion in which dread of fatness persists, the widespread endocrine disorder involved in the hypothalamic pituitary gonadal manifesting as amenorrhea in women, and loss of sexual interest and potency in men. If the onset is pre-pubertal, puberty is delayed or arrested. With recovery, puberty is normal, but the menarche is often late. In bulimia, the psychopathology consists of morbid dread of fatness, and the patient sets herself or himself a precise weight threshold well below the pre-morbid weight that constitutes the optimum or healthy weight in the opinion of the physician. There is often a previous history of anorexia nervosa ranging from a few months to several years. The diagnosis is made by the history taken, physical appearance and behavior of the adolescents. The SCOF questionnaire is very helpful for diagnosis. The questions are: do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone or 3.6 kg? Do you believe yourself to be fat when others say you're too thin? Would you say that food dominates your life? 1 point should be given to each for every yes answer, and a SCOF index score of more than 2 indicates a likelihood of anorexia nervosa or bulimia nervosa. The physical signs are including underweight, hypertension, thinning of hair, swelling of parotid glands, enamel erosion, less tolerance to cold and hypothermia, dry skin, lanuga hair, insensitivity to pain, constipation, bloating, dizziness, insomnia, amenorrhea, shrunken breast, etc. The treatment: recovering from an eating disorder is not just a matter of simply eating healthy. Treatment works to change these thoughts and behaviors, but they don't occur immediately. The effective treatment is tailored to the needs of the individual, including a multidisciplinary approach of a therapist, dietitian, and psychiatrist or primary health physician. Obesity is another concern because it is associated with current as well as future health problems. The BMI is not irreliable in case of adolescents. Intrauterine environment also plays a very important role. Large for gestational age infants have a higher risk of obesity and indolence compared to the normal weight infants. Whereas black adolescents are more sufferers. Now these are the related disorders and consequences. I'll just skip over it. Now obesity is 20% low weight, extra weight over the ideal body weight. Is usually as a result of poor eating habits and less of physical exercise. Okay. Management is lifestyle changes, drugs, bariatric surgery, and screening. Early detection and management of metabolic conditions. Now this is the prevention, lifestyle intervention, dietary advice. Now the most important place is the counseling. We still need to talk and talk about the patients, and we have to be understanding and also understanding the disorders. These are for maintaining factors. Now, patients and prognosis. Now, the goal is the nutritional rehabilitation and a set point weight maintenance, normal eating behavior, healthy thinking about weight, appropriate treatment plan with behavioral and pharmacological therapies, increased family awareness, and relapse prevention. The mental health treatment has cognitive behavioral therapy, antidepressants, self-help plus, brief therapy, interpersonal therapy, and dialect behavioral therapy. This is phase 1, 2, and 3 of the congenital cognitive behavioral therapy. That is focusing on regular meals, not to skip any meals, then modifications of thought, and prevention of the relapse. Antidepressants. The overview. Eating disorders are potentially life-threatening. 10% of them die. Now, to support them, there should be new ways of thinking about themselves, and new behavior should be tried. Now, pica, this is the last one. This comes from a Latin word magpie, a bird which eats anything. It's an eating disorder in which non-nutritional objects are eaten. It's characterized by compulsive craving for eating, chewing, or licking non-food items of food containing no nutrition. Now, this is the thing. Now, effects of pica are malnutrition, severe stomach ache, muscle weakness, and brain damage in children, and infertility, increased blood pressure, nerve disorders, and muscle joint pain in adults. Treatment is again same, cognitive behavioral, and forbidden food should be known to the patients. Thank you for the patient hearing.
Thank you, ma'am.
Okay, thank you NACHCON Society for giving me to chair this session, eating disorder in adolescence. Dr. Anju ma'am has well explained all the topic related to eating disorder in adolescence, and we all get benefited by her talk. Thank you, ma'am.
Thank you for kind words.
Thank you. Can we have Dr. Kanak also here? All the chairpersons. Ma'am, we want you here. Dr. Kanak, please join us.